this on, but,
Now it is.
okay.
Jim Pfister's online too.
Oh, he's online?
Yep.
Okay. Perfect. So, my question was whether this was part of the old budget year or the new budget year. The agenda indicates that we're still in a continuation of our current budget year, so I'm going to go ahead and welcome you this morning. This is the health services presentation, which we've done in the last 3 years, I think, and so we're going to, at this time, turn it over, I assume, to Janice and let you get us started.
Okay, thank you. We have a PowerPoint, and I am waiting to see it on my screen. Okay. Good morning, everyone. My name is Janice Garceau. I'm the Director of Health Services. I'm here with my with Health Services leadership team. So to my right is Holly Harris, the Director of Behavioral Health. To my left, immediate left, is Cheryl Smallman, our Business Officer, and our new Public Health Director, Heather Keisner. And then in the back of the room is Chris Weiler and Jillian Weiser, almost the same last name, but not quite. And they are respectively our operations officer and our quality and compliance assurance officer. So they're here in case there are some additional questions. We are going to see if my clicker works. It does not. Is it? Oh, it's off. Well, that might help if I turn it on.
This keyboard might be part of it too. I don't know if it is.
No, I actually hadn't turned it on.
Oh, there you go.
Okay, so the agenda for today is we'll do a health services overview that's very quick. Cheryl will cover the fiscal year 24 proposed budget. Holly will cover behavioral health updates and special requests. I'll do a little piece on IDD, intellectual and developmental disabilities. We'll cover public health, special requests and information, administrative services, and wrap up. We've tried to build in as much time as we can for questions because we know that there are always questions of interest, so we will get to those. It is okay to ask questions as we go along, but if you can wait to the end of a section, that can also be helpful because we may be covering something you're asking about in the section. So the mission of health services, as you know, is to promote and protect the health and safety of our community. That mission has never resonated more deeply for us than during the past 3 years as we navigated an unprecedented global health emergency. We are forever changed by what we've been through together with our community. This past year, we faced many challenges related to recovery. Workforce shortages, a housing crisis that impacts both those we serve and our staff, health inequities that were painfully illuminated by several crises, and less than needed resources to meet the needs of some of our most acutely impacted people in the community that we serve. We also saw opportunities. They manifested in the form of behavioral health investments, successful efforts to incentivize recruitment and retention, public health modernization, as well as what we learned about our ability to adapt, sustain, and continue to care for the community during one of the hardest times in recent history. We're incredibly grateful for the opportunity we had to bring the full force of our skills, energy, commitment, and love for our community to the task of protecting and sustaining lives during the pandemic. And we're proud of what we accomplished together working across silos, building new skills and relationships, managing rapid response and change, all while maintaining our commitment to science, excellence, and compassion in the provision of care. Today, we'll share our current status and budget requests for the coming year. You'll see what we've done to use county investments wisely, leverage additional resources, and demonstrate meaningful results. We're aware of the fiscal challenges facing the county today, and we hope you will see evidence of that in our work to return general funds, keep asks to a minimum, and apply existing resources to solving our own problems. With that, I want to thank the members of the Budget Committee for making your time available. I know that some of you are volunteers and others of you serve our community every day. We recognize that this work is important and that you bring a lot of attention and curiosity and interest to it, and we appreciate that. So thank you. So This is just a quick reminder of our 3 primary service areas. Behavioral health, as you know, offers crisis services 24/7, access through intake and integration of primary care, psychiatry, intensive adult services, intensive services for youth and families, a number of outpatient complex care clinics that are integrated with primary care, and our intellectual and developmental disability services. Currently, that has 271.8 FTE, which is slightly more actual persons, since some of those FTE are part-time. We also have public health services. They provide community health or environmental health, emergency preparedness and recovery services, prevention and health promotion, advancement and protections, and clinical and family services in a fairly broad array, and they have 99.7 FTE. And our administrative services service area, which basically makes our work actually possible. That's our business intelligence team, our operations teams, and our compliance and quality assurance program, and they are made up of 46.3 FTE. So we were asked to spend a little bit of time on challenges. I've already referred to some. We really have faced, along with the rest of the country, historic and prolonged vacancies in critical roles, in particular primary clinical roles, psychiatry, nursing, some of our public health roles, and even in admin services we've had shortages. Also, this caused impacts to access. For the first time in a long time, we didn't necessarily always meet our access to care timelines. It affected some of our outcomes and certainly caused a dip in revenue. Housing, we've talked about. I don't need to belabor it. We are struggling both to find safe places for the people we serve to live and, frankly, to find places for our staff to live in our community. We are noting a growing acuity in our service population. We're just seeing significantly more unaddressed illness that is in the community, partly as a result of a shortage in access to treatment beds and the long-term impacts, I think, of COVID and isolation on individuals with mental health conditions. And we've seen increased impacts on those who are most impacted by emergencies, which are often some of our underserved or more marginalized communities. And last, we're trying to keep pace with the growth we've had in recent years. So we have certainly expanded, and we haven't necessarily kept up with our physical space and with our infrastructure, and we'll talk a little bit about that. But one of the things I just want to say is when we took a look at our growth, we had something near 40% growth over the last few years in our service arms and 4% growth in our administrative services, which is really not tenable long term. So that's something we are going to be thinking about over the next year. Opportunities. We continue to be a certified community behavioral health clinic, and we are trying to maximize on this new team, this new leadership team, integrating behavioral health, public health, primary care, and figuring out what we can harness together to increase the health of the community. We're bringing a lot of the lessons we learned from multiple emergencies to our emergency preparedness work. And we are looking ahead to a future that probably is going to expect us to mitigate some threats, disease outbreaks, increases in communicable diseases, climate events that are affecting populations in a significant way. We also hope to apply some recent investments to target populations and high-need service areas like perinatal women and children, unhoused individuals struggling with mental illness and addiction, at-risk youth, and other vulnerable populations. And with that, I will turn to my colleague, Cheryl.
Thank you. All right, I'm going to make reference. Is that mic working? Yeah, great. Make reference to your binders. Each of you should have at least received one. There's a lot of information in there. We're not going to go through all of it, but I wanted to at least point you to several key tabs. not to diminish the ones I don't highlight, like the annual report, which is really great, but the department level financials provide a summary by fund. We have 3 funds. Fund 270 is the first one. That's the Behavioral Health Reserve, or OHP, Oregon Health Plan Reserve. Then Fund 276 is our Regional Acute Services Fund. You'll note no expenses in that particular fund this year. We've moved that to the next fund, which is Fund 274, our operational fund. That's where we're going to spend the majority of our time, but if at any point you have questions on that, the other funds, feel free to ask. The other tab that I wanted to just highlight is the program level financials. The first sheet is a summary of all programs. It is my personal favorite of all the sheets in that binder. I might be partial in general to it, but it does summarize the budget from fiscal year 23 to fiscal year 24, so you can see how that changed, how general fund changed, how FTE changed in any one program, as well as service areas. So then behind that one are program financials summarized by service area. That's the green sheet, so behavioral health, then followed by the main categories for each program in that service area. So that kind of gives you a roadmap of how you can use the binder. If at any time we need to dive into one of them, I'm happy to do that. But for the discussion, I'm going to try and keep it pretty high level. So on the slide above is a pie chart that talks about health services funds, just general overview, and this is the operational fund, Fund 274 specifically. If you wanted to see the actual numbers, you would go to the department level financial tab and look at Fund 274, the third page in. Overall, you can see that government grants and payments is our largest category of resources. This is 42% of our fiscal year 24 proposed budget. It's a decrease of 11% from the previous year, and it's primarily related to either COVID funding either ending or starting to tailor off, as well as one-time investments that we had in the behavioral health workforce in fiscal year 23. Those were about $3.2 million specifically allocated to that we expended last year, received and expended. Capitation and fee-for-service make up 27% of our resources. That's an increase of 33% from the previous year on budget. There was sort of an unprecedented or unexpected, rather, mandated fee increase on the behavioral health side, and that was retroactive to January. So we will have received some of that revenue. So that net change in revenue was actually more like $1.2 million, I believe, but in budget, it's an increase of about $5.3 million. You'll see we put the additional revenue in Fund 270 for fiscal year 23. Charges for services make up 4% of the budget. That's an increase of 23%, which is about $550,000 increase over the previous year. This is primarily due to a proposed rate increase to environmental health of 10%. That is included in the proposed budget. That makes up half, so about $250,000. The other half is related to a new-ish program that is Family Connects Oregon. Heather will be talking a little bit more about that, and we have a special request tied to this, but it's bringing on commercial providers, so we're projecting that revenue will increase. And related to the environmental health fee increase, we're proposing a reduction in the transient room tax of $50,000. So that's a decrease of 12% from the previous year. And then county general fund is proposed at an increase of 3%, so that would bring it to $6,780,140. That's primarily related to public health base county general fund amount increase of 4%, which is tied to the COLA. So that comes to about $172,000. You'll see some offsets there as we had one-time marijuana tax funds that came through that line item. Next year, $60,000 will come through a different line item. and then an increase from fiscal year 23 on healthy schools. So that's 69,000.
A quick question, if I could, on that.
Great. Yeah.
You're pulling from the county general fund. I know that you're also returning a fair amount to the county general fund this year. Would you have otherwise pulled from your reserves, or would you have, rather than returning them to county general, or would you, or were you always intending to pull from county general?
Our intention, well, let me rephrase this. The county general fund increase is primarily only on the public health side, which doesn't have reserves. We would be returning, we plan to return $168,000 on the public health side of county general funds, which is about what we're asking for in an increase. So in essence, you could think we're just asking to carry forward that $168,000 unspent. That's related to the health officer special request that was approved last year. We do anticipate, and in our forecasts, we've assumed that public health's county general fund, the base county general fund amount, would increase equivalent to the COLA, but not the full increase in personnel of merit increase and COLA.
All right, thank you.
Yeah. Good question. Okay. So on the topic of county general fund, and I feel like Mr. Pfister sort of teed it up, here is how the county general fund compared to our overall revenue, excluding beginning working capital. So the new revenue being brought in every year is the light blue. The dark blue on the bottom is county general fund amount from 2018 to our proposed budget in 2024. And then the red dotted line is the county general fund is a percent of revenue. So what you see here is that other revenue is continuing to increase, so we're bringing that in. That change from 2018 to 2024 is roughly 18 million in new other revenue sources, and the change in county general fund is about 2 million between those years. And you see here the county general fund as percent of revenue has been oscillating between 8% and almost 14%. So we do plan to return nearly $1.2 million in county general fund in fiscal year 23, or roughly $1 million is on the behavioral health side. Those county general funds that we're not returning are primarily used for match in this current fiscal year, as well as some policy decisions that have been made. We've kept that county general fund in the program. So one example is the Crisis Stabilization Center staffing support of $241,000. That is not part of this $1 million being returned. The other component is the 50% county general fund for the health officer position, which we have a candidate identified and anticipated to start, what?
July 1st.
July 1st. So we would be returning that or just carrying it forward. One thing to know about county general funds on the public health side is it really helps us deliver services that are mandatory but not billable. So that's important to note. On the behavioral health side, we generally apply it to the highest acuity needs. So you can see in the summary sheet for all programs, program level financials. Crisis is one of those services, older adults, so you'd see that intensive services, but also where we can leverage it for match revenue. So that would be IDD and other programs throughout. In fact, in fiscal year 24, we anticipate 1.9 million of the 6.7 million proposed county general fund would be leveraged for an additional 3.8 million in other revenue sources. So if we were to decline or decrease, not put forward that $1.9 million, we would be giving back the 3.8. In terms of requirements, this is how it's broken up primarily. Our biggest expense is personnel at 62%, which is a decrease of 2% from the previous year. We'll talk about this a little bit more in a few slides forward, but we do propose our FTE is going from 422.8 to 411.8 without special requests. So that's part of it. We have built-in vacancy savings as well. Departmentally, that's about 8%. It varies for each service area. Behavioral health is right around 9%. Public health is right about 6%, and administrative services is at 3%. So that all washes out to roughly 8% in vacancy savings. Materials and supplies make up 20% of our expenditures. This is an increase of 3% over the previous year. It's related to many of these one-time expenditures, which I'll talk about more in just a minute. Our ISFs are 6% of our expenses. That is an increase of 18% from the previous year. Half of that is related to facilities, so we have increased our square footage at North County, but the other half, roughly half, is increases in other internal service departments. Major one-time expenses that are in our proposed budget. One is the Lapine Community Health Center, where we anticipate the building and we intend to contract with them. That expense is roughly $1.4 million, so you'll see that in the contracted services line. Behavioral health housing, we anticipated to spend that in fiscal year 23. Due to a number of factors, we anticipate that would just be expensed in fiscal year 24. This one is specifically related to the secure residential treatment facility space in North County. So that is $3.8 million budgeted in fiscal year 24. Behavioral health workforce funding, we did receive notice that we'll be receiving additional funding to stabilize, recruit the behavioral health workforce. We have a number of programs that we hope to launch, including a more robust internship program so we can start to stabilize the workforce. That is roughly $900,000 budgeted. And then we have a number of capital requests. Some of that is related to moves for various space decisions that we've made. Either we're moving between lease spaces because we can get more square footage for a reasonable expense, but also to integrate, as Janice noted earlier, more on primary care and our services. So the capital requests specifically, we have two related to vehicles, and then capital expenses related to these space moves. That's about $300,000. In addition to the capital expense for space moves, there's another $1 million in M&S that are one time. Questions? That's a lot of information really quickly.
So the 3.8 million that was for the secure residential facility that Best Care had backed out of, so what are we planning on doing with that then, that 3.8 million?
We are talking about that now. We have a couple of projects that we're thinking about. Remember that those dollars have to be spent on an adult population that's at risk for incarceration or other outcomes because of their mental illness. So there are a couple of special populations. We have some sort of forensic populations that we think about, folks that are coming into contact with law enforcement a lot, and we have looked at a project there. That one is very much in its infancy. The other thought that we are having, and that has some real legs, is IDD individuals who cannot be, so we have adults who are intellectually and developmentally delayed, have mental illness. They are in the ED constantly. They get arrested. No one will take them because they either say, we won't treat you because you have IDD, or we won't treat you and house you because you have mental illness. So we're looking at a project, and I think it's the one we're feeling more confidence in, to stand up a local housing option that's a treatment housing option for that population. So it's not an SRTF, but it would address a very, very, very vulnerable high-needs population that's tying up a lot of ED and law enforcement time. Anything you want to add?
No, I mean, I think I think that's one of, probably the project that does have the most legs at this point, but we are still really exploring a number of, options related to what we could stand up, fairly quickly, spend the money within the time frame and meet the target
When does the money
population.
have to be spent by?
Great question.
I don't know that they've been extremely clear about that. My guess is at least by the end of next year,
Yeah. I think
next fiscal year.
Yeah, I think it was by 2025.
Yeah.
And so just when thinking about housing options, it definitely is a tight timeline.
Yeah.
We're talking calendar December 25 or fiscal?
I'll find out and get that to you right now, probably.
I think it's fiscal year. I think it's the end of the fiscal year, but we will find out for sure.
For the
next
Lapine
one is
Community
me.
Clinic partnership, 1.4 million this fiscal year, what's that going to specifically?
So that is the project that has come to the board several times where we are co-locating. We lost our primary care co-location in Lapine during the pandemic. That's a community that we really need to serve in that way. And Lapine Community Health has cobbled some money together to build a new facility, and they really wanted us to co-locate with them. So that amount is the tenant improvements. Tenant improvements, yeah. Yeah.
Yeah, because I know there's ribbon cutting like this, late this summer or something, or not, but groundbreaking.
Groundbreaking, yeah. Yeah, I wish ribbon
that's
cutting,
different.
but we'll get there. So it's really, I mean, that project for the community is, I think it can be really pretty amazing. Okay, so I think I have the next slide. So just some of the fiscal issues that we are thinking about and that are on our minds this year. Short term, I think everyone is familiar with the fact that OHP redetermination is underway. So beginning in April, the action that happened during COVID that allowed people to stay on OHP and not go through the normal redetermination process has ended. And so OHA has rolled out a lengthy period to allow people to determine whether they can maintain their OHP or not. But at the end of the day, what's anticipated is that this year, the enrollment in OHP will drop somewhere between 6 and 13%, and when it's all said and done, by the end of next year, may drop up to 25%, depending on what happens in the world, as always. What that means for us is that this 33% investment in behavioral health, which comes to us through our capitation contract, won't yield the sort of revenue that it would have had we not had this redetermination phenomenon on the horizon. So the way we get paid is a huge chunk of our contract, is a per member per month amount. So that's literally members, dollars. When members go down, dollars go down. The concern we have, and many safety net providers have, is that our enrollment does not, in fact, go down because we tend to serve the folks at the lower end of the income sort of scale and with high risk and high needs. So we don't anticipate a decline in our service population. In fact, we may see more people who can't access Medicaid services in the community and we must serve at the same time that revenue may decline. So that's one biggie that we are keeping an eye on. Everybody knows that personnel costs have increased significantly. Our indirect costs also increase. So that's really related to increased costs for things like health insurance, costs for services downtown, and just the phenomenon that we absorb both our personnel cost increases and we also absorb as a department the increased cost of administrative personnel outside of the department. So it just means that when personnel costs go up, it can be a bit of a double whammy for us. Expiring funds, the COVID emergency ends May 10th. We're all thrilled about that. But that also means that the dollars stop, literally, most of them. And the phenomenon that public health has shared with me is that very frequently there's very little recognition that some of what was built during an emergency, some of the risks that were addressed during the emergency don't necessarily go away, but the dollars sure as heck do. And so we just know that we have to be mindful of that. The Community Justice, what is CJC?
Criminal Justice.
Criminal Justice Commission grant, the IMPACTS grant, and this is the grant that many of you know has helped to fund a large chunk of the cost of the stabilization center. I would say about 20% of the cost. And we've had for 4 years.
Yes.
is likely not to be funded in the next biennium. So that chunk of resource that helps support stabilization center operations is likely not to be there. So we've covered that cost in the coming year, but it's just a reality that we're facing as we think about how to sustain this really critical resource in the community. Long term, we talked about public health funding. It really was flush with cash during COVID, and that cash is going away. And the modernization funds that we were anticipating are coming, but they are not coming as robustly as was hoped. I've talked about the stabilization center. We're addressing lots of space needs, but the space needs downtown continue to be a concern for us. And we've talked about client acuity and the service model that we are operating out of, which is a less, I don't know how detailed you want me to be about how we generate revenue in behavioral health, but we used to do a very kind of private practice outpatient-y sort of model in a lot of our facilities, and because our service population has really changed, that is not the model anymore. We're doing a lot of team-based care, a lot of outreach and engagement to people that are not yet enrolled. All of that means non-billable services. So things have shifted. The revenue-generating power of an outpatient model where people churn through an office, it's just not what community mental health looks like anymore. Jim, do you have a question?
I do. So
Yeah.
Specifically around the stabilization center, just a couple pieces of follow-up. One, do you think that there's any chance that some of the homeless funds that the state is assigning could be directed to the stabilization center, given the population that it's supporting?
The current governor's emergency associated homeless dollars, is that what you're talking about?
That's I mean, because that's at least a reasonable chunk coming in. I didn't know whether any of that could be allocated or requested for the stabilization center.
It can't be. The window of what that can be used for has gotten even narrower since it first rolled out. So it's really about shelter beds and sheltering people. And the stabilization center, while it supports an enormous number of unhoused individuals, does not shelter. In other words, it doesn't house people for any length of time. So that funding is, at best, we might be able to get some dollars for things like basic needs items, but we have some of those dollars available, so that's not going to be an opportunity. We're hoping that some of the crisis funding comes through. There was a lot of talk about funding stabilization centers. We're not necessarily seeing that manifest at the legislature. So we're going to be thinking about how to cover that cost over the next couple of years.
Okay, and then just a different tack on that. I know that, for instance, the sheriff's office transferred a fair amount last year.
Right.
Have you considered approaching the various law enforcement agencies for some type of prorated charge to be able to help that?
We have approached many agencies with requests to help offset costs, and we have had pretty profound help from the sheriff's office. The city of Bend did help fund one position related to our non-law enforcement response, and some of those dollars also offset some stabilization center costs. But other than that, we really have not had people stepping forward to offer to help offset some costs for this resource.
Might be good to do just a uniform ask or a uniform bag in this case to try and do it. I mean, specifically, I know that law enforcement speaks incredibly favorably of the stabilization centers, and so asking them to put their money where their mouth is would probably be beneficial.
Thanks.
Jim, can you comment on how such a request might be received at the Sun River Service District?
I think the Sun River Service District, I don't know, I'd have to ask the chair or something, but I bet you that the Service District would be pretty interested in understanding what the ask would be and how that would take shape over time and how they would budget for it, yes.
Right.
Thank you.
If I get a chance, I'll ask them.
Thank you.
What about COHC? Have we asked them again this year for their funding?
Well, COHC, so our CCO really, frankly, did us a solid in the negotiation this year. They increased the commitment, to the stabilization center through the PMPM, through the per member per month rate assigned specifically to the stabilization center by the 30%. That was up for question, and the whole committee, negotiating committee, ultimately agreed to do that. So that meant we went from roughly 500,000 or 600,000 to a little over 800,000 that we anticipate. But of course, as redetermination occurs, that amount will go down, and that's a concern because our service population won't. I can guarantee you that, especially not at the stabilization center. COHC funds, really, they envision those funds as intended for initial investment and startup. So we did get considerable dollars from COHC, and we don't think that's an opportunity.
We did get it like 3 years ago,
Yeah.
but we got it again
Yep.
last year.
Yep.
So I'm just thinking it is continuation. And what are the homeless numbers now, Holly? What is the percentage of homeless that are at the stabilization center?
We're still hovering around 17%. of
Okay, I was
people
thinking
who-
18, so
Yeah.
it's really consistent.
It is,
Yeah.
and with those COHC dollars, the second round of COHC dollars we got were a match for the impacts grant. So we wouldn't have been able to get those had we not gotten the impacts grant. And so unless we get another grant where we can get another match, I don't know what other opportunities are available at COHC, but we will always be looking that direction.
Always.
Yes.
Janice, what's the amount of the 20% for the CD?
1.2 million a year, or 1.4?
about-
1.2?
It's about 1.2 a year.
Yeah.
Going back to the question of how the state and the legislature are thinking about supporting crisis services, I just wanted to ask, so we did hear about that legislative initiative to put a fee on phone bills that would support 988 and crisis services. Is that basically the primary thing that the legislature is looking at for support of crisis services this year, or?
I would say that was more in support of probably the hotline services that were going to be provided. You know, part of 988 rollout at the state level really was supposed to include things like non-law enforcement response as well as stabilization centers as part of this continuum of crisis services. The money just isn't there for all of that. So right now the focus has been pretty heavily on just making sure the hotline services, the 988 number, is fully functional. There's been some piecemealed funding to get the non-law enforcement response going. We were fortunate locally to have the investment from the city of Bend to help get us fully 24/7, but most communities did not get enough to be 24/7. So stabilization centers are just sort of like the last piece of it, and because most places don't have a stabilization center, it's not been to the highest priority, though it still is a state level expectation that we move in that direction. We just need they haven't identified funding for it yet.
And so there's the impacts might be going away, but you're not aware of any other kind of replacement policy that's working its way through this legislative session.
Not this session, no. It's definitely an enormous amount of advocacy happening, calling attention to that fact that you just pointed out. The combination of impacts funding going away along with that phenomenon is problematic for us locally, for sure.
And it's interesting because the state points to our stabilization center as a model program, brags about it nationally, invites people to come and visit it, and somehow has not figured out a package of funding that would support things like this, because they are costly offerings. They just are. So, and even the crisis funding that's being rolled out for non-law enforcement, we're having pretty hot conversations with the entity that's calculating how the enhanced Medicaid rate is going to pay for that. They are basing their calculation on the notion that 75% of who people serve in crisis are OHP recipients, and that's just absolutely not true. It's probably much closer to 55 or 60%. So they're building a whole financial structure on an expectation of who's served that's actually about 15% higher than reality. So we're still at it. You can talk with us about who to reach out to if you'd like. I want to turn it back over to Cheryl unless there are other
A
questions.
little bit of follow-up
Yeah.
on stabilization. So,
Yeah.
during this budget process and, going into next year even, maybe we just start to think of this as, a one-pager, some bullet points for the legislature, for our local jurisdictions, value to public safety, you know, really even have a brochure about, you know, the great things we do and how we need, and this is for everybody, we need to have a long-term, stable funding plan.
Yeah,
So, yeah, I mean, I'm just thinking kind of marketing around it.
Yeah.
Let's make sure that it's its own,
yeah, I mean, we'd love to work with Whitney and her team on maybe putting something together. Yeah,
you know, celebrate
it's a
its
good idea.
successes and
Yeah,
advocate for stable funding.
And we have plenty of data to demonstrate our outcomes, so
Yeah.
that won't be a problem.
nope.
Is it still 3% Crook County?
Yes, still hovering around 3%,
What about Jefferson?
about 1%.
One,
Yeah.
still one.
Yeah.
Okay. Before we move on, I did want to follow up on the behavioral health housing. We need to incur or obligate the funds by the end of December of this year, and our contract ends April 2024.
Okay.
So, we're working on that one. So, long-term, here's how health services looks. This is not a new or different view, so to speak. What you have in front of you are all health services funds, so that's all 3 of our funds, back from 2018 and then forecasted out to 2027. The dark blue on the bottom is county general fund. Light blue are all other government payments. More deep blue is capitation and fee-for-service. Then the yellow is the CCBHC prospective payment system, that's PPS. So you can see where that was quite prevalent in 2018 and even in 2021. But as our capitation has increased, you're going to see that yellow component decrease. And then the beginning working capital is green. The dotted line are expenses. We are using, when we're forecasting out, we're using historical trends, which is a little bit difficult in health services, especially given COVID, and it's historical trends for this particular time frame. Personnel, we've assumed if it's limited duration, that expense ends at the end of its limited duration status. If it is regular and it is on a grant, the grant funding ends, but the expense continues. This also, as we stated earlier with Mr. Pfister's question, it assumes an increase on the public health county general fund equivalent to the COLA. So that's 4% in 2025 and then 2% and 2% in 26 and 27. So that is our assumption. We also have assumed that we have a 13% OHP redetermination. So our capitation is going down because the enrollment goes down. What that means is that overall there's a gap in 27 of about $11 million. We've ran different scenarios because this is based on assumptions, including a new program that is launching, Family Connects Oregon. We've looked at different scenarios on capitation and enrollment, depending on when that starts, how much is being redetermined not on OHP, and whatnot. So we have, in a surprising scenario, we would see an increase in revenue this year of about $600,000, but then it's a steady decline thereafter. So we are going to expect some fluctuations based on that, based on how the scenarios roll out. I have a worst case scenario, which changes this graphic to the gap goes to $13 million. So it doesn't necessarily surprise me at this point in time, because last year when I was here in front of you, we had a gap, and that gap was in 2026. So you can see that that's pushed out a year, and this is a little bit of a phenomenon with health services. We had a 30% rate increase retroactive to January that we did not anticipate, and sometimes that funding just happens. So we add in the 10% surprise. That could be either new funding that we are unaware of that could come through, or fewer expenditures that the funds could be rolled over. This is not atypical. Looking at the historical trends, this is relatively normal. Any one revenue stream fluctuates between a 50% increase or a decline, so it is varied based on what we're looking at. Overall, what that would mean is that we're good through 2026, but there is a remaining gap in 2027 to meet our requirements. That's about $3.3 million. That's on the public health side. So to that end, breaking it out is probably helpful to see how this shakes out. Here is the behavioral health budget. So they have all three funds. And you can see in 2027, that gap is $5.5 million.
Daryl?
Yeah.
CCBHC, maybe let's get back to the big picture of what that is, because I'm surprised that it's just fading away. What is that?
Trades off.
Did we think that was going to happen? I mean, I thought we were building an infrastructure that would kind of go on.
So a couple of things happened. We didn't think that was going to happen. What happened was a pandemic and then an increase in investment in behavioral health. And both of those things impacted how the CCBHC model of payment works. So the most simple way to think about CCBHC is it pays the difference between your cost and your reimbursement. When your reimbursement is high and your cost goes down, your CCBHC wrap payment goes down to zero because you're basically able to cover your cost with your existing resources.
Is that federal when you say that? Federal dollars that are?
Those are the federal match dollars. The other thing that happened, so there were really three factors. There was declining referrals during COVID and declining billable service hours. A. B, we had increased investment in behavioral health, which affected that relationship between cost and reimbursement. And C, we had OHA busy doing other things, and they did not get back to rebasing the CCBHC cost formula. So they are doing that now. So what that means is they're reimbursing us based on their evaluation of our cost in 2016. So that should tell you something. We hope that with rebasing, with increased billings, we're already seeing teams getting very busy again, and with possibly declining OHP revenue because of redetermination, we may be generating some CCBHC revenue again in the next year. Cheryl has estimated, if rebasing goes well, that we might generate.
Well, it's two factors. If rebasing goes well and we increase our services by 11%, we'll start generating revenue again. And that assumes a 13% redetermination.
Yeah.
So a lot of inputs that are moving, and we're watching to shorten that or close that gap.
So when CCBHC from 2020 to 21, it kind of just drops off. Is that, was that making up other government payments or capitation? You know, I'm just thinking which one was it making up when you were able to, you're saying, you know, we have a service and that made up the cost of that service. Which of those lines?
Primarily in capitation. Yeah.
Complemented capitation effort.
Yeah. And that is the right relationship, right? It is intended to cover uncovered costs, and if capitation is covering those costs, you don't ask for more money. But the unfortunate thing is that all of those other factors then were also at play. Lower service hours, not having rebased the actual cost formula, which means it's really not based on true cost anymore. And that's, you know, we've taken a hit for that. We hope that will right itself, but the behavioral health investments certainly were helpful to offset that. So, and the resources that we generated that we hadn't planned because of that cycle we went through where they kept saying, oh, it's going to end, and then it didn't end, and oh, it's going to end, and it didn't end, and we saved those dollars. Those are going to be critical for us now. So
generally in the estimates, the 1920, the capitation plus yellow looks kind of like 23 and 24. I mean, it, you know, I'm just looking at a block diagram here, but I mean, it does, the resources, we can kind of think of them as there, but yeah, it still doesn't add up to what we might need.
it might not. Yep.
So capitation and CCBHC both depend on the number of people enrolled in OHP.
No, CCBHC wrap payment is based on the number of claims you submit, the degree to which those claims are reimbursed at a level that covers your cost or not. So the PPS rate is a payment you get on a claim that you submit after you've reached your reimbursement, and then your costs have exceeded it. So if you're upside down, you don't get to submit claims. If your relationship is here, you've submitted, you've been reimbursed, but you haven't reached the threshold of that cost to reimbursement ratio where you're in a hole, you don't get to submit claims for the reimbursement rate that's enhanced. So it's incredibly complicated, but that's kind of how it works. Dan could probably tell you more. Cheryl could tell you a lot more.
I would just say that as capitation goes up, CCBHC is going to go down because CCBHC is the remainder after you deduct your quarterly capitation payment.
Right.
So the more folks that we have on Medicaid through this, the more folks we have on Medicaid through the state, the more capitated dollars that health receives, the harder it becomes to generate CCBHC dollars, because after they total all the claims for the CCBHC, they have to deduct that total amount against the quarterly capitation they receive. So they kind of offset each other, and that's what you see in this graph, is that as capitation grows, the CCBHC shrinks. And I think what health is saying is that capitation may shrink next year, and the CCBHC rebase rate might be a little bit higher, so they might have some CCBHC next year.
Yeah.
So this is a projection, but in reality, maybe the blue part is smaller and the yellow part is bigger.
Well,
That's the hope, yeah. Yeah, is that they offset
They'll-
each other.
they'll- okay.
But since one is is paid on members and the other on the number of services we do, it's not a one-to-one. We need to do more services to get the same amount as membership goes. During COVID, I think you had mentioned this, but really quickly, groups, the decline of groups really
Huge.
impacted our PPS amounts.
huge.
Groups.
Group treatment means you get just a lot more, you're submitting a lot more service hours for an individual claims, and it just really helped us generate revenue. Eric?
CCBHC comes with lots of requirements,
Yeah,
and some of them are excellent because they improve outcomes in terms of co-locating with our physical health. But some other requirements we may not want to continue. If the amount that we get from CCBHC goes down, at some point do we say we're not doing this anymore? Not to say that we wouldn't continue some of those practices, but just because of all the requirements.
yeah, the state is actually asking itself the same question. Actually, most of the requirements, while they're onerous, are really positive. So remember that that's screening for depression, doing things like checking people's blood pressure and weight, screening for suicide risk, screening for substance use disorders, and screening kids for suicide risk. So there's nothing in that list of requirements that's objectionable from a clinical perspective. Yes, there are administrative hurdles because you have to collect data to prove you did all those things. And that's always where the rubber meets the road, right? It's not the act of doing it, it's proving you did it through your medical record, which is what drives people kind of to distraction with administrative burden. But frankly, the requirements of CCBHC, most of them we're going to continue to do. We're going to continue to screen people with evidence-based tools for depression. We're going to continue to connect them to primary care. We're going to continue to do multidisciplinary team services. We're going to continue nursing. I mean, these are good practices. But yeah, there are some of the rules that are onerous.
And I would just say, besides the fact, when I look at health services, besides the fact that CCBHC has good metrics, and the data team has done a great job of pulling those metrics for years, if something was to happen with OHP or Medicaid, CCBHC is a massive safety net.
Yes.
And you would see that yellow bar grow to
Exactly.
$6-7 million every year if you started losing that capitation.
That's right.
If you were to get rid of that, you don't have that
Right.
revenue safety net. Yeah.
So we should all hope that the legislature decides to continue this model because it is life-saving and it is a safety net for community mental health. Okay, I don't want to take too much time.
No, that's great.
Is that it for CCBHC? Okay.
10% surprise on the behavioral health puts us solvent through 2027, though we don't meet our contingency requirements at that point. Public health, this has a gap about 5.4 million when we're looking out through 2027. As we stated earlier, doesn't have much in terms of billable or revenue generating programs, except there is Family Connects Oregon that Heather will talk about that holds some potential moving forward in that sphere. There are also two other elements that we have our eyes on that can impact and lower this gap. One is public health modernization. We've been hearing that the funding from OHA will increase, but we do not know how much. We should hopefully find out this legislative year, and so this assumes no change in public health funding, as well as COHC quality incentive metrics for public health. Historically, public health has not been part of that distribution. When COVID hit, it became part of that distribution. So it's ongoing receipt of that revenue we are uncertain of. So that may come through, but in our scenarios, we have not counted on that coming through. During COVID, that was $1 million each year, roughly. And it's based on the community meeting certain metrics and then a surplus in the budget. Behavioral health has always been, or at least in the most recent future, been part of that, and it's built into their contract. So we have assumed they receive that revenue. So that could come through. With a 10% surprise, that does lower the public health gap to $3.3 million in the out years. So recap, funding potentials that we're keeping our eyes on: public health modernization, we've assumed no change, could come in higher. We didn't mention this, but we'll talk about this more in the presentation. The intellectual developmental disabilities workload model works on a biennium. This is that biennium. We find out in July whether or not that funding increases or is level or decreases. The last several bienniums that it's increased because it's based on population. We're hearing that it may be level, so we've assumed that it's level. And then we've talked about CCBHC PPS rebasing. We've assumed no change. Hopefully that comes through. We've talked about OHP redetermination and how that can impact us, as well as public health COHC QIM dollars. So these are all things that might come in higher that would lower those gaps that for which we are aware. Staffing. Fiscal year 23, we're going from 422.8 to 411.8 without special requests. Here's how that divvies up. We had 2 positions that ended at the end of March. They were COVID positions. We will be ending, or it's the end of a limited duration public information officer position. 6 additional COVID staff that are limited duration slated to end at the end of June. We have 1 administrative staff that is limited duration, technically ending at the end of December of 2023, but we're ending it early due to less revenue than we had anticipated on that fund, or earlier than we had anticipated. And then Community Health Specialist 3 in prevention. It is regular. It is currently vacant. It would be ending. We have a proposal out to use opioid settlement funds. If that is approved, that position would continue. But that's how we get to 411.8. Oops. I did want to note that there's an additional 5.5 positions that are limited duration ending throughout fiscal year 24. In the proposed budget, when that position terms, we've assumed that that expense also is removed. So know that that's already built into the proposed. We do have 3.5 of those limited duration positions that are tied to a special request, so we'll walk through that. So, a little preview. We have 5 special requests, and in priority order here that each service area is going to go through. Healthy Schools, year 3 of the pilot program. Sure.
Off the top of your head, okay, so you have 422.8. How many unfilled positions do we have with that 422? Like, the end of last month. Is it still like 40 or something?
That does not sound outside the realm of possibility, but I can get you that
It is
number.
closer to where we've always been historically.
Yeah.
Right.
We've been running about 9% vacancy departmentally, which is not abnormal. That's more normal than we have historically.
Okay.
So,
Just a reminder, I think I shared with this group at the mid-year meeting, and I can't recall if the budget committee members were there at our mid-year budget meeting. But we did a little deep dive into the number of positions that we've repurposed. So we've had a number of vacancies. I think the total was 19 throughout the year that we repurposed. Some were more costly, some were less costly. The sum of that repurposing of 19 existing FTEs was $40,000 to the good. So that doesn't show up in these presentations, but we want you to know that that's work that goes on all year long, where we try to make use of, move positions around, fill them in the ways that they need to be best utilized. And the ultimate result of that was 19 FTE that were repurposed, changed, better used, and cost less at the end of the day. So I just think that's important to know, and you don't see it because it happens behind the scenes, but that's another way that we manage our cost. So,
Yeah.
okay,
that's 42.7
Okay.
filled or unfilled.
good guess.
Well,
Fantastic.
I just it went down a bit.
Yeah. Okay, so 5 special requests, 2 in public health, 2 in behavioral health, and 1 in admin services. Healthy Schools Year 3 pilot program, just a continuation of that. That is currently in the proposed budget, so the county general fund overall would not increase based on what you see in front of you. The second one is to convert, I'm not even going to try and pronounce the whole title. Holly will do that later, but we call it PIPBIC Supervisor. That ends currently at the end of December. The third one is Family Connects Oregon and Perinatal Care Program. That would be adding 2 new positions, though staggered, and continuing 2.5 limited positions. The fourth is converting 8 system of care. It's a SAMHSA grant that is actually through August of 2024, converting all of those positions to regular, and then converting the senior DEI strategist position to regular.
And whoever can tell us what PIPBIC means at the end of the morning gets a chocolate bar. Let's hope you remember.
If we all agree on it.
Right. Hi, everyone. For those of you that don't know me, I'm Holly Harris. I'm the new Behavioral Health Director as of January, but not new to the county. I've been with the county a little over 10 years, most of that, if not all of that time, spent in overseeing our crisis services. So excited to be with you here today for my very first budget presentation with you all. So I first want to talk about what a community mental health program is and the responsibilities of it. So at a high level, it's really the local mental health authority, i.e. the Board of County Commissioners, designee to meet all the various mandates that are required of us, both rule, statute, and contract. Just at a kind of a basic level, though, the community mental health program really is responsible for serving the most vulnerable people in our community. People often at risk of incarceration, at risk of hospitalization, often people that our community partners are either unable or unwilling to serve, and so we really become that safety net provider for our community. So we have core services that are required of us, our crisis services, justice system related services. So 24/7 mobile crisis, for example, is required. Serving aid and assist and civil commitment is also required. But we also provide that safety net service that's required in rule and contract. So jail diversion is an example. Our homeless outreach teams is another example of that. So serving people that are extremely vulnerable and unhoused in our community. And then we're also responsible for coordination of the local comprehensive plan for behavioral health services. We also provide some additional services that really no one else does, which is, our kind of example of a school-based health center services that we offer, and really our community outreach and community-based outpatient mental health and substance use disorder treatment. So we've been fortunate, as mentioned before in both Janice and Cheryl's presentations, that we have received some investment in behavioral health these last couple of years. A lot of it has been around crisis services, so I'm very familiar with those in my previous role. A lot of investment to make sure communities have 24/7 crisis response, which we have been fortunate to have here for nearly 20 years. But really the investment this year was around making sure we can respond to those crises without law enforcement. So that requires an additional investment to increase staffing so that we can do that work safely in pairs of 2, 24 hours a day, 7 days a week. So we actually just rolled that out as of May 1st, so just the other day. And so it's very exciting to have that program up and running. It's been a long time coming, but we're really excited to see the outcomes related to that. CCBHC is another example of an investment. Through that effort, we have been able to leverage a 3-to-1 match, which is, incredible. And as we mentioned before, doing a lot of good to help support people with both their physical health conditions and their mental health conditions. We have co-location with primary care in every one of our spaces, which really helps address costly chronic health conditions and risk. So we're seeing some good outcomes as a result of this. The Stabilization Center has consistently seen approximately a 30% diversion from the emergency department for people served at the Stabilization Center. That number the numbers actually increase each year that we've been open. We're seeing a 15% increase in primary care assignment. So these are people that did not have a primary care provider that now do have a primary care provider. So you can imagine the benefits to that individual's overall health as a result of that. We have robust suicide screening for both children and adults as required by our CCBHC, but also just a good practice, good clinical practice, and we're seeing reduced depression scores.
Quick question on that. Do you think that the change in the Oregon Health Plan is going to affect that primary care assignment rate?
Well, people can be assigned to primary care providers that receive Oregon Health Plan dollars or not. So, I have a primary care provider. I don't know. It won't affect our internal rate. So that rate is really about our clients who are assigned to a primary care provider. So a lot of the people we see come in and they don't have a doctor. They haven't seen a doctor in 10 years. If they're 22, that's probably not as big of a concern. But if they're 50 and have some conditions, it is a concern. So that rate really is referring to our success at using our model to get people connected to medical care. And that shouldn't go down because, as I said, even when OHP goes down, the number of people we see doesn't go down. And our FQHCs are the primary people we refer to, so they're not likely to decline either.
And our case managers, this really is a focus of our case managers. While many of our case managers are OHP assisters, they are also just case managers that are working to reduce barriers to access to care for the people that we're serving. So that means connecting them with a private insurance provider for primary care or OHP or whatever the need is in that moment.
All right, thank you.
Thank you. So some of our accomplishments, we've seen a 76% increase in care coordination for those enrolled in both behavioral health care and primary care. And the Stabilization Center has, as you know, been both recognized at the local level, at the state level, and at a national level. In fact, we're just receiving another award for the Community Resource of the Year from the Pacific Northwest CIT committee. So that is very exciting. I think we've received 3 at this point already. So it's very well respected and nationally recognized, and we're very excited to be able to offer that for Deschutes County. And we are consistently, like I mentioned before, seeing an increase in the people that we're diverting from the emergency department, which really is one of our primary goals there. So we saw 23% more individuals were diverted from the ED in 2022 over 2021. Retention, we talked about workforce issues. We have seen an impact as a result of the investments that you all made, as a result of the investments that the state made around retention and recruitment. And we have seen reduced vacancies by 6% and help stabilize our teams and increase morale because, as you know, just because the vacancy's there doesn't mean the work stops. So we had increased workload for many of the people that remained. And so that's been a hardship for them for sure. Measure 110 and ARPA dollars increased our homeless outreach and harm reduction by 12 FTE, which really helped expand our intensive outreach and engagement into the community, particularly in our rural areas as well, for those with substance use disorders.
Can you tell me about those 12 FTE and the outreach? Do you know how often they're going out and providing outreach and services to those populations? Is it weekly? Is it once a month?
It's daily.
Every day.
It's daily. They are a very, very active community-based team that is hitting every part of Deschutes County. So they're in South County, they're in Sisters, they're in Redmond, they're in Bend, they're everywhere, and they're out there every day, and they are meeting people where they are, going into homeless camps, going to where people are in shelters, navigation center, wherever the need is, they go. And they are showing some really tremendous outcomes as a result of their engagement work.
Okay, great, thank you.
That question.
And that team, just for clarification, isn't actually 12. That 12 includes our harm reduction program. So we don't have 12 people that we can use to go out into the community to address houselessness. Is probably closer to a total of 7 or 8. And then the other staff on that team are doing opioid prevention, other harm reduction efforts, often in coordination with, but not necessarily the same work.
Okay, thank you. That was my other question.
Yeah.
Thank you very much.
So some of the challenges on the behavioral health side, so we see tremendous growth here, obviously. The acuity is rising, but unfortunately our resources in terms of placements has kind of remained stagnant or even gone down in some cases. So we have a lack of psychiatric housing resources, such as secure residential treatment facilities, access to the Oregon State Hospital, which we have not had in years, and no child residential psychiatric placements in our community, which really puts an extra pressure on providing community-based services without access to higher levels of care like we need. Workforce challenges, despite our efforts for improving our vacancy rates and all the efforts we've done, we're still seeing higher than historical averages for our key positions, particularly our master's level clinicians, what we refer to as our QMHPs, incredibly difficult to still hire for regardless of some of the work we've done. We've seen some improvements, but we're still not where we need to be. And Oregon, the way Oregon's structured, it really is pretty heavily QMHP dependent in order to provide our services and bill for them. Obviously, the opioid crisis is real. It's here. It's hitting us hard as well, and we've seen an 85% increase in overdose deaths since 2018. And then, this is a piece that, we talk about a lot, and there's a lot of advocacy happening at the state level, but really the micro-regulation that occurs at the CMHP that does not occur in our private practice panel and elsewhere. So this really is kind of a direct correlation to our workforce issues, as the CMHP has enormous amounts of requirements, rules, statutes that govern our work and audits and so forth, that a clinician could leave the CMHP, go to a private practice, and they will not have the same level of administrative burden, and they will often get paid, the same or more in some cases. So it's a challenge to really work with the state to reduce that administrative burden, and we're hopefully making some headway on that. Some opportunities ahead, though.
Can I ask a question?
Oh, yes.
One of the challenges with the workforce, and of course we're continuing to see that across the county, across a lot of different, as the public sector, private sector, everybody is too. And then going back to the accomplishments, the retention efforts have been reduced with, as you mentioned, the incentives provided. So my guess is a lot of those people that had received the incentives are on a 2-year stay agreement or something of that nature. So does this challenge actually increase after, I don't know what date, 2024 or 2025, when the stay agreements are satisfied? Do you see that workforce challenge increasing, or do you expect that, the commitment will remain and people will largely stay? I'm curious about your perspectives.
Well, we have not
where that goes.
had these types of investments here before, so it's a bit of an experiment to some level. I will say, just from kind of anecdotal experience with the retention, it seems the people who are going to stay are generally going to stay. Now, there's a handful of them that did solely stay just for the money in the stay agreement. Not solely, but, that definitely helped them commit to another 2 years. And those people may still have to make a decision for themselves. And some of this other stuff I've talked about, though, the administrative burden, the lack of resources, that really plays into how much they're liking their job and how much they want to stay continuing to do this work. So that's why we have to hit it from all angles, not just retention bonuses, in my view. I don't know if it.
Yeah, I mean, the other thing I would add is I think there's some legislation working its way through the process this legislative session that will allow us to have a little breathing room around how we incentivize workforce. We have some resources that we can apply to that. We've worked on a tuition package that we think will be really robust. We're working on, in my role, I am really focusing internally again. So working on organizational culture, working on the ways that we're supporting staff internally, working on ensuring that our supervisory level is well-trained and supported, because that is actually the key to retaining workforce, is having good supervisors. So we're working this problem from every angle we know how. We will also apply these dollars to paid internships. That's a great way to grow passionate, young, committed, dedicated, hardworking professionals. So we're looking at all of that. So we'll see.
Yeah.
We'll
And
see.
what I will say is the hiring bonuses, though, do seem to be one of those things that is really helpful, especially trying to recruit people to move to this expensive community. And so we're really watching the pay equity stuff closely in the legislature to see how that all plays out. So the opportunities really are around the investments. I mentioned the historic investments, that 30% rate increase that Cheryl mentioned in her presentation, really critical, especially as redetermination happens, and knowing that that's not going to be, we're not going to realize the full 30% probably because of some reductions elsewhere, but it certainly helps us not take a bigger hit. Housing investments, we talked about this with the House Bill 5202. This was going to be the SRTF, Secure Residential Treatment Facility, that we had with Best Care, but we are regrouping and looking for new ways to invest that to address the very first challenge that I mentioned before of our lack of placement opportunities. We are expanding services into Redmond. Long overdue. Redmond is a very fast-growing community, and the need is great out there. So the investment that happened around getting our campus expanded into our new location is very exciting. We'll have new youth drop-in center there that we have in Bend that will now be in Redmond as well. So that's really exciting, and hopefully at some point the expansion of crisis services out there. COVID-19 recovery, we are returning to robust in-person services. We've been doing in-person services for a while now, but we're seeing it increase, especially now with the mask mandate lifted. That really is pretty critical to our work. If you can imagine being in crisis and trying to serve someone in crisis, or any part of our organization really, and having a mask on and not being able to see the person's face, and them not being able to see your face, and trying to do some really difficult, hard work, that just added that layer to our work that is now not there. And we're pretty excited about that in terms of engagement with our population. So on to our special requests. So this is really related to our integrated care team. So PIPBIC, also known as Promoting Integration with Primary and Behavioral Health Care. Got it. So this is a supervisor position that was funded out of this grant. This grant is ending in December of this year, but this supervisor position has become integral and critical to our integration efforts with Mosaic Medical. So this position oversees 9 clinical staff, is the primary liaison with Mosaic, really coordinates the care, that ensures good outcomes, tracks and reports on all the various metrics that we have, and as really is our expert leadership to that particular team. We've seen some great outcomes as a result of this position and this program. Really, that 91% of our shared patients between Mosaic Medical and behavioral health have been seen by a provider in the last 30 days. That may not sound like that big a deal, but with our population that often struggles to engage in services, to know that they are engaging, within 30-day period is actually pretty impressive at 91%. And of those patients, 82% have seen low emergency department utilization in the last 6 months, which is also impressive for this population. And 80%, so this last metric really gets at what we're trying to accomplish with integration. That 80% of adult outpatient clients with hypertension met their goal of hypertension control. So we are really seeing improved health outcomes, which is going to improve the quality and longevity of the individuals' lives that we serve. So the ask in this special request is to convert one behavioral health supervisor limited duration to a regular position. The cost of that is $85,613,000. And we expect to be able to cover that with OHP revenue, so no general fund is being requested to cover this position.
And just one clarification, that 85,000 is for 6 months because the position ends December 31st. So the entire fully loaded cost is about 171,000.
Thank you, Cheryl.
And this is the same grant where we are not continuing the other position that was funded with these grant funds. So just the supervisory role.
Correct.
Can I just ask about this program?
Yes.
So do the referrals kind of flow in both directions, or is it mostly in one direction from Mosaic to us or from us to Mosaic?
Both. Yeah, the goal really is that we are able to get people into Mosaic as quickly as they're able to get people into behavioral health. COVID definitely had an impact on our ability to do that in the way we wanted to do it, mostly because of staffing shortages and people not being in person, all of the things. But we are reinvigorating our effort to make sure we can get some type of same-day access on both sides for people who identify with either a behavioral health need or a physical health need on either side. So it's pretty great to have them co-located to do that work.
Thank you.
And just to be clear on this is a person, not an unfilled requisition, right?
Correct. This is a person, a longtime employee. I think she's been with
15 or 20 years, I
Yeah.
can't remember. This is a very long-time employee. Yep. In the role supervising a team of nine.
And in limited duration status that whole 15 years, or?
No.
Took the limited duration status to do this specific work and had been a lead and then became a supervisor through this grant, and really has a passion for primary care integration work. So definitely a longstanding valued employee.
And one other item to note on this, OHA has advised us to add this particular expense into the rebasing formula. So PIP-BIC is something they want to continue even though the grant itself is not continuing. So they're looking for other ways to continue it, just if that helps.
I just have to say it one more time. Promoting integrated primary behavioral health care. Did I capture that?
Almost.
Okay.
No, it's
Integration of.
Oh,
Okay, yeah, sorry.
we're getting technical.
Alex.
No chocolate bar for you. Half a chocolate bar.
So our second special request is really related to our system of care program of staff. So this was a SAMHSA grant, a 5-year SAMHSA grant that is, as Cheryl mentioned, ending in August of 2024. This grant was written primarily because of the CDC data showing suicide as a leading cause of death among Oregon youth ages 10 to 24. So it's got a specific focus on high-risk youth in our community, because we know that, as you see on the slide here, that at about 50% of youth decedents had a mental health problem at their time of death of a suicide, and that about 1 in 3 youth suicides were engaged in mental health treatment, which is not necessarily something we see on the adult side always, but on the youth side. So that just tells us the critical nature of us having a very specific focus on reaching high-risk youth population that are involved in mental health treatment. So our wraparound program does that incredibly well. We know at-risk youth have poor school engagement, are often at risk for out-of-home placements, often at risk for juvenile justice involvement as well. And so this team, this SOC team, really targets that particular population. And they provide enormous cross-system collaboration, intensive support, outreach to children, youth, and their families. And these kids have very complex co-occurring needs. So this grant actually helped us expand our wraparound services in Redmond, Sisters, and Lapine. And one of the really great things about this program, that some of the outcomes we've seen, is that, despite this group being at very high risk of not enrolling in school, we've seen a 94% of wraparound program graduates are enrolled in school at the time of graduation. So that's a pretty significant number, especially given what the historical averages for this population are around school enrollment. So our ask on this special request is to convert 8 FTE from limited duration to regular. The cost of that is $889,739,000. And we do expect to be able to cover that with OHP revenue and the enhanced case rate that comes with us having these positions that help us leverage other dollars. So no general fund is being requested for this special request either.
So Holly, we actually sent the letter to address the issue of adding 4 hospitals for youth in our state, one of them being here, hopefully. And because of this, 1 in 3 of these were engaged already. Do they actually need hospitalization? Because if 1 in 3 are committing suicide, even with someone working with them,
So, some do. I mean, they're getting children hospitalized in an inpatient psychiatric setting is incredibly challenging, as you know, in our
Right.
community. We don't have a placement in our community. Oftentimes, they linger in the emergency department for weeks on end while we wait for a bed to become available, which is incredibly traumatic for our youth. So we do a lot of work to try to keep them in the community as best to our ability, but we need this intensive wraparound support and to be able to do it safely. And then there are those cases where it really isn't safe for them to be in the community, and they do need that higher level of care, which is why if we could get something.
Is there only like 1 now in the state? Like by
No, there's more than one, but there are none on this side of the
Right, none on
valley.
this side.
Yeah.
Okay, well, hopefully, maybe we'll have some divine intervention and we'll get that through.
It'd be wonderful.
Yeah.
I can give a little update on that. When I was in Salem yesterday, I stopped by Representative Sanchez's office and spoke with her legislative director, and he was pretty confident that now that the bill is into Ways and Means, and Representative Sanchez is one of the co-chairs of the Ways and Means Committee, that the bill was going to pass.
Oh, that'd be great. Long overdue.
Yeah, and they certainly indicated that they would be very interested in our region being a location. So
And
we'll see.
And while I was there, I made sure to invite the representative and her chief of staff to come to the tour that we are someday going to get set up for legislators and our congressional delegation.
Yeah.
That would be great. Thank you for that advocacy.
When the session is over, probably.
So I have 2 more slides about IDD. That'll take us right to probably a nice time for a break, and also give you time to stretch your legs and be ready for Heather talking about public health and wrapping up. So does that sound like a good plan? Okay. Intellectual and Developmental Disabilities Program is a CDDP. What is a CDDP? It is a designated program by the state to provide the core services that are required for individuals that qualify as having an intellectual or developmental disability. They serve everyone in the community that is IDD. They provide eligibility services, abuse investigation for adults, very critical piece of work that is often not known, but they're looking at cases where people that are IDD have been harmed either in residential facilities or in homes. So they're our county's investigator for that. Foster home licensing and certification, and significant case management services. So most of our staff are doing quite a bit of case management. Our IDD population is growing, although it did not grow quite as significantly in the last year, but you can see there a graphic of the growth of the IDD population. And we really have, and I know I'm biased, but we have one of the best IDD programs in the state. They're often recognized because they meet lots of service targets that other programs struggle to meet. For example, completing 100% of service plans. So every single person they touch has a service plan. It is up to date. And that's meaningful because that's the vehicle that families and adults and children with IDD actually get to access services. In addition, we're one of the counties, thanks to the investment of our county commissioners through policy decisions, that gets to participate in the local match program. So local dollars, if they're made available and the program achieves their service targets, we are able to draw down roughly a 2-to-1 match in additional dollars to cover costs of the program. Our IDD program regularly achieves these targets. This year, they were 35% over their base target, so the minimum you have to meet to get minimum match, and they were 8% over their target for maximum match, so to maximize the amount that they can draw down, which is really quite an accomplishment. So how does the model work? This is a complicated slide. I wasn't going to have it show up all at once, but there it is. So IDD services are funded through what's called the workload model. That's actually a concept embedded in the rules and the legislative statutes that support our IDD programs. And basically what that is a model that has created a formula that forecasts the caseload based on population, then assesses the workload based on a period of time that they actually track real work, divided by the minutes available per FTE, and that is the sort of funding formula for the workload model. Every year it's funded less than 100%. So the legislature says, great, thank you, we got your workload model, this is what it's going to cost, and we'll fund you anywhere from 86 to 94%, depending on the year. I think last year was the first time, was it funded at 100% or close? Yeah, I can't recall, but it was one of the higher investments. This year we anticipate it won't be that high. So county general fund is applied to cover the additional operating costs, but also those additional operating costs are covered by the match dollars that pair with county general fund. So what you see, actually the ratio is a little better than I said. It's $1 buys $2.60 of IDD match to cover the total cost of the program. And that is really it. Oh, it's not it, sorry.
There's another slide.
There is another slide.
Yes.
I'm going to let Cheryl cover this slide because I think she does a better job with it than I do. Did you have a question, Jim? Sorry.
Yeah, is that formula based on a book rate in terms of minutes required to do the work, or are they actually tracking per patient the minutes that they're spending with the patient?
Yeah, they're actually tracking. So there's a period of time where they track people's activity in the they track it a number of ways. So they track emails, they track minutes of service recorded, they track any activity related to the work for a period of, I think, 2 weeks. And that's how they get the workload piece of that formula.
So this is another form of micro-administration that you were talking about earlier.
Yeah, people love that 2-week period. They just look forward to it every year. It's a party. Yeah.
Woo.
But in this case, it at least results in a realistic assessment of the cost of doing the work. We wish we had that in other areas of work because it's a model that has actually allowed legislators to have actual real-time annual information about what it costs to do this work. So it's kind of phenomenal and seems like a good idea. We wish we had it everywhere, but we don't. So.
Okay, so what's in front of you for the fiscal year 24, I should say proposed budget, that's my bad, is that we're proposing moving some county general fund from other programs within behavioral health over to IDD so that it can meet its match requirements to essentially cover its full expense. In IDD, the county general fund is $876,000, $876,559. But the match component that specifically goes to that is only $541,139. That leverages or gains us an additional $1.4 million in federal funding. So it's a total, what you see in a line item is 1.9 million. That's how that's broken up. We send them a check, they send it back, plus some. That county general fund need could adjust come July if we find out that we have more funding, then our county general fund need would potentially go down. But I anticipate it's at least going to be stable, and that's what we would need to meet next year's costs at maximum match.
And this is one we never know until after the budget is final. So this is a phenomenon some of you who have been with us over the years are familiar with.
Yep.
Ready for a break? Okay.
Take a scheduled 10-minute break.
Heather.
Can you hear me?
Go ahead.
Okay, I think we can get started. I think it's still morning, right? Good morning. As Janice mentioned, I'm Heather Keisner. I am the newly minted Public Health Director as of March 1st. Really excited to be here with all of you today. So I'm just going to do kind of a little background public health, really kind of ground us a bit into what we do. So as local public health, it really is our job to protect the public's health from the spread of disease and promote health in our whole community. Each local public health authority is really required to deliver or assure all of these services that are listed here in this slide. And so while some of these programs provide really important direct service, such as our family planning clinic and our WIC clinics, the majority of these programs really do touch all of us and work quietly behind the scenes to keep our community healthy and safe. So I know we have been talking a lot here, and I want to do a little activity because it wouldn't be public health if we didn't do an activity. So I hope you all amuse me a little. One thing I just want to kind of bring up is, what does that really mean on the ground? Like, how do we protect and serve everyone in our community? So with your help, I'd like to just take a couple minutes to walk through a day in the life of public health. And those of you who've been through county college years ago may remember this activity because I think I started it. And it really gives us concrete examples of what we do and how we impact everyone who lives, works, and plays in this county. So Chris just passed out some strips of paper that I think some of you have in front of you. And I promise this is simple, but when I call your number listed on the paper, just read your example. So I'm going to start us off. The alarm clock buzzes. Stumbling out of bed, you head to the bathroom to brush your teeth. The water coming out of the faucet is clean and safe. Number 2.
Oh, great. After waking your children, you go to the kitchen. Of course I do. Mornings are rushed, but you've been to a Taste of WIC, sponsored by the WIC program, where you learned how to prepare an easy, delicious, nutritious meal.
Number 3.
You take your child to school knowing that they will be protected from serious childhood diseases like measles and polio because they receive their vaccinations. Public health works with pediatricians, parents, schools, and daycares to ensure access to immunizations in our community.
Thank you. You got a long one, sorry.
I did.
Number 4.
You head to work. As you go in, you notice that a new no smoking or vaping sign has been posted. For years, public health has been educating people about the deadly health effects of tobacco and secondhand smoke.
Number 5.
Your sister called. She and her new baby have just received a visit from a public health home visiting nurse. She is feeling more confident about breastfeeding and receiving tips on how to promote better sleep and soothe her baby.
Number 6, right?
For lunch, you head to the plethora of food carts in Deschutes County. You naturally assume the food is safe to eat because public health inspects, educates, and licenses all restaurants and food carts.
Number 7.
It is the end of your workday. As you are driving home, local radio is warning of bad air quality for the next few days. Thankfully, local public health is coordinating with healthcare providers and emergency manager to help prepare our community and provide tips on how to limit your smoke exposure.
Number 8.
You receive a newsletter from your child's school and see a reminder of the importance of talking to your child about alcohol and other drugs, and are excited to learn there is a workshop for parents organized and hosted by the Healthy Schools Public Health Specialists.
And number 9.
Before bed, you check on a loved one in a care facility and learn a norovirus outbreak is happening and the facility was running short on PPE. A couple years ago, we would define that, but we all know what PPE is. Luckily, they reached out to an infection prevention nurse in public health and within a couple of hours received several boxes of gloves and gowns, as well as education to keep their staff and patients safe.
Thank you all. So these are just a few examples of how public health touches our lives in countless ways, really working behind the scenes to keep our communities safe and sound. Okay. So some accomplishments this past year, well, really these past few years. I do just want to start with, we know it's been a really challenging few years for public health and all of us in this room. Lots of dedication and work to respond to a global pandemic. And as our COVID-19 public health emergency ends this month, I just want to note that Oregon was in the top 7 states in the continental U.S. to prevent COVID-19 deaths. And here locally, public health continued response efforts related to the COVID-19 pandemic. This include coordinating 338 community vaccine clinics around our county, distributing 41,000 at-home COVID test kits, and really coordinating over 48,000 volunteer hours. And so I really also want to take the opportunity to thank all of our Deschutes County volunteers for their incredible work and for all of you for your support during this time. So, some other exciting things and accomplishments this last year. So through public health modernization investments, we expanded programming and services both locally and regionally. Our regional infection prevention nurses responded to over 180 outbreaks in high-risk congregate settings, such as our long-term care facilities. And our environmental health team expanded the drinking water program, conducting 71 private well samplings to test for nitrates and chloroform bacteria. Modernization funding also created capacity to develop an indoor air quality program, offering assessments and safer air education to vulnerable populations during wildfire season. So some of our challenges, those of you who have worked with me for years know that outbreaks are something that I stay awake up at night. And unfortunately, 2 challenges I want to talk about today going into this next year. One is already happening. We have a lot of syphilis happening in our community and in our state and in our country. Syphilis cases have doubled since 2020, and we currently have 31 syphilis cases so far just in 2023 in our county. At this time last year, we had 8 syphilis cases, so this is a 275% increase in cases so far this year alone. These numbers may not seem that high. However, back in the early 2000s, really there was a goal in public health to eliminate syphilis, and unfortunately the numbers are going in the wrong direction. Another really concerning trend is the increase among heterosexual men and women, which is contributing to the nationwide increase in congenital syphilis. And for those of you who aren't aware, congenital syphilis results from untreated syphilis during pregnancy and can lead to stillborn infant death and serious birth defects, including brain and nerve problems. And it's tragic because this is preventable. With syphilis, if you get tested and you get screened, you can get treated. So public health response, we have really ramped up provider education in our community. We're going out to all of our clinics, providing a lot of education, awareness, and ensuring access to screening. We're also ensuring access to screening during pregnancy. And our nurses provide rapid treatment of cases and contacts to prevent further spread. So another concerning trend is our increasing our risk for outbreaks as our childhood immunization rates. So Deschutes County is the 4th highest for non-medical school vaccine exemptions, which you can see on this map. This means parents who are choosing to exempt their children from needed school vaccines. Also, OHP child immunization rates are down almost 20% since 2019. We're still waiting to receive overall immunization rates for all children in 2022, but concerned that these will also be down. So one exciting project that we've re-implemented in public health with the help from a Central Oregon Health Council grant is the Immunization Quality Improvement Project, which kicked off in late fall of last year. And this project really works with clinics to help increase their immunization rates by ensuring best practices. And so far we have 18 enrolled clinics. And when we implemented this same project back in 2016, pre-COVID, we saw an 8% increase in our childhood immunization rates. So we know it works, and we're really optimistic that we can reverse the trend. Okay, so some opportunities. So we want to continually actively prepare and respond to current and emerging threats. You know, in my 20 plus years working in public health, I've been through a lot of different public health emergencies, and often what happens, as I think Janice mentioned, the money kind of flows in, everybody rallies, everybody works together, the emergency ends, and we kind of all forget. And I really want to ensure that we keep kind of that core emergency preparedness program going to really ensure that we're prepared for the next emergency. And I also want to continue to engage our over 160 active volunteers, which is incredible, and provide ongoing outreach to our vulnerable communities, as well as continue that coordinated, timely risk communication on public health threats, which is key to making sure our community stays resilient. I'm also excited to announce, I don't think it's even been announced yet, we've recently been approved to be a designated medical reserve corps. And this is a national volunteer organization and really helps us provide structure, training, and continue engagement with our robust volunteer pool. And it also provides opportunities for funding. So that's going to be an exciting new program to really kind of maintain that engagement with these really robust and excited volunteers. Another opportunity is a continued and hopefully increased state public health modernization investment to support local public health foundational programs, such as our emergency preparedness program. And I do want to thank our commissioners for their continued advocacy for modernization with our legislature.
Heather?
Yes.
The public health modernization funds, how prescriptive are those funds in terms of the state saying, here's some money, but it has to be used for X?
Yeah, so we kind of, back in 2016, every public health department did an assessment of where our gaps are for kind of those core public health services. And they're slowly rolling out the funding. And right now, the focus is still communicable disease, emergency preparedness, and environmental health for foundational programs. So it needs to kind of be spent in those areas. Another opportunity we have is to increase our revenue and access through Family Connects Oregon, which I'm going to go to in a couple slides because we have a special request there. And this is a universally offered nurse home visiting program being rolled out across our entire state, and really kind of is an exciting opportunity for public health. As Janice and Cheryl mentioned, you know, a lot of what we do is not revenue generating. It's really population-based public health. So whenever we have opportunity to get revenue, I am all for that. Okay, so I'm going to go into, we have two special requests today. The first one is healthy schools, and I know this topic has been discussed numerous times in the past, and you've all received quite a bit of information on it, but just want to give a little bit of a reminder of what the program is. So Healthy Schools program is a partnership with Ben Lapine Schools that brings the expertise of public health directly into schools and to the district to proactively meet student and family needs and address gaps. The public health specialists, which you can see on this slide, provide coordination for prevention planning and health resources to address school, student, and family needs, supports to health teachers to improve prevention education, as well as supports to schools to improve substance use screening and referrals to treatment. Healthy Schools focuses on topics such as adolescent suicide, vaping, social media risks, alcohol and other drug use, as well as other emerging risks that may keep students away or disconnected with school, which increases the likelihood of negative consequences into adulthood. So year 3 is the last year to phase in Healthy Schools staffing to bring the program to 100% staffing levels and coverage for all Ben Lapine high schools and their feeder middle schools. Thus far, Healthy Schools program evaluation indicates it's being implemented in a manner that will achieve change and impact. Fall of 2025 will be the first analysis on student health outcomes, but short-term and midterm outcomes really are available now through our 2022 annual report, which we have online on our website. So we are requesting to add in fiscal year 24, 1.0 FTE Public Health Educator 2, and this would be assigned to Caldera High School and its feeder schools, High Desert Middle, and Three Rivers, which is K through 8 down in Sun River? Yes, Sun River. And also asking for an increased approved year 3 county general fund amount by $23,096, and this is due to higher personnel costs than originally approved. correct, for year 3. And just a reminder that this is a 50-50 match with the Ben Lapine School District. Oh, question. Jim?
Just if I could ask a question on that. I thank you for the review that you gave to the county commissioners. I reviewed that offline, and it was very informative. The 2 questions that I don't recall it answering, one would be, do we think that the other school districts in the county are long-term going to latch onto this, or are they pursuing this in a different way? So that's my first question.
I have not heard yet of the other districts that are interested yet, but I can reach out to my manager and see. But I have not heard anything pending on the horizon at this point.
Okay. I mean, because my concern is just, long-term expanding costs on this. Obviously it's a good program from what we're getting. And then the second was, we have a lot of results already on the teacher side, and some of those are very encouraging. But when do we think we're going to get our first student baseline? My understanding from last year was that probably next year is when we'll actually see some of the student baseline results back.
Yeah, so the Healthy Student Survey, we're going to be able to see that in 2025 in the fall, and so that's where we're really looking to see what impact this program has had on a lot of these topics that I just addressed. Does that answer your question there? And I can get more information to you on that as well.
And I think we should think really critically about that data, because what we're comparing it to is a period post-COVID. So I'll be, one of the conversations that Heather and I will have is, can we use our data analytics team or a research partner to compare a like community that did not have this programming in place? Because I think a lot of what we're going to look at, it's going to be hard to suss out what are we seeing that is the sequelae of a pandemic that kept young people out of school. And is our community looking better even so compared to a similar community? So I think that's a conversation we need to have about how to think about the data and actually make meaning out of it, and not just give you data. So we're going to do some critical thinking about that.
Yes. Yeah. And I would also add that in talking with the team, as I've met with them, there is a lot of interest in this program at the state level and even at the CDC level, and so we're constantly looking for opportunities there as well. But it's really exciting to see a lot of these other agencies and schools, and even the Oregon Department of Education, who are really interested in understanding this program more and looking at the data as well.
Can I just answer Jim's first question by saying that in discussions with the superintendent of Redmond Schools, Sharon Klein, he was indicating much more interest in partnering with the county on clinical behavioral health services in the schools. So, not a prevention kind of population level approach, more one-on-one services, which are billable, and which, the school doesn't have, licensed clinicians, so they are not able to access OHP funding for those services provided. So that would be his angle, was, get county behavioral health people into the schools, into the Redmond schools to provide clinical services, and OHP would cover at least a substantial amount of the cost of that. And I think that was in terms of what he thought his district would be willing to pony up some funds for. He would be more interested in a partnership like that than the Healthy Schools partnership at this time.
Yeah, he approached us about that partnership. I think there's some. I think we probably have some educating to do about what Medicaid billings alone actually pay for, and what the cost of adding those roles would be. And we've invested in the school-based health centers, which provide those clinical services. So we're not uninterested, but it would be we'd have to do a really deep dive on how to make that work.
Yeah,
but yeah.
But just to answer Jim's question.
Yeah.
From that discussion, it didn't seem like a request to extend healthy schools to the Redmond School District was imminent.
Yeah, we have not heard that they've not inquired about doing that.
So with the numbers, we're talking about $23,000 this year. But really, we're a 50% partner with 6 positions, so it's probably about a $300,000 program out of the general fund every year.
It's technically a $408,000 on the county side for year 3. And then same on the Ben Lapine School.
Yeah, so the 23 is making up how we got here, but it's really a bigger number annually coming into it.
Yeah.
Yes.
I just want to bring up something that's called Healthy Schools, but actually communicating the other day with Representative Emerson Levy, we have our schools in Deschutes County that serve low-fat chocolate milk to our kids. I'm like, oh my gosh, all that sugar that is in low-fat milk, and we're still serving that in today's world. I don't understand why the schools haven't really cleaned up what they're feeding the kids. I mean, it really needs to be a lot healthier. What do we have, like a 20% obesity of children now in our country? It's frightening what's happening, and as health leaders, I really feel that needs to be addressed. It wasn't just in Ben Lapine. I've heard the same thing from Redmond.
Yeah.
I will bring that back.
Thank you.
Mm-hmm.
I know you will.
Jim, did you have a question? Nope. Okay. Okay, so my final slide is in Public Health's final special request is Family Connects Oregon, which I briefly touched upon. So Family Connects Nurse Home Visiting is now available free of charge to every family with a newborn in Deschutes County and across our state. A nurse visit families in their homes to assess the health of a mother and infant and provide comprehensive connections to community resources that support the long-term well-being of the entire family. This is a really highly effective program and has been studied in rigorous randomized controlled trials and rolled out in multiple states. And the evidence has been really clear that Family Connects program lowers costly emergency medical care and improves family outcomes. The service consists of 1 to 3 visits from a nurse that includes a health check for mom and baby, support with infant feeding, bathing, crying, sleeping, and swaddling, education about what to expect as the baby grows, as well as home safety education and parenting resources. And so the state, a couple years ago, the legislature is now a requirement to offer this program to all families. It's completely voluntary, and it is now also reimbursable by all Oregon insurance. So we have had a successful early rollout here in Deschutes County, especially with our OHP population, and are really starting to see an increase in enrollment for our private insured population. And really, we need to be prepared here in Deschutes County for around a 60% increase of families who will want this service. And this is really based on other states who have also rolled this program out, such as, I believe, Texas. So we are asking for a 1.0 Public Health Nurse 2 to start in July of 2023. And then we're going to, phase this in as enrollment increases and we see more need, to then add another 1.0 Public Health Nurse 2 to start in January. We're also requesting to convert 2.5 FTE from limited duration to regular, and these are our 3 perinatal care coordination team that many of you may know and have heard about. They really are integral to the success of Family Connects and are embedded in our OBGYN clinics and are key to really just success of Family Connects and many services that support new families in our community. They're a central and trusted point of contact and provide really that easy access and enrollment to services for all perinatal clients. This team also acts as nurse extenders, so they can provide medical care coordination for the nurse home visiting program and clients, and are now able to bill for some of these services so our nurses then can see more clients. The cost is a little over $499,000. There is no county general fund requested, as we expect revenue from enhanced Medicaid and commercial billing rates. So that's all I got.
Is that going to be a nursing
Just,
opportunity in private practice also, or is this just a,
It's through public health. Hmm.
so you can start your nursing program for this small town and go do this?
I don't think so. It's really being rolled out in every county through every local health department from OHA.
So there's one nurse proposed starting in July. Would she be or that person be responsible for seeing those 1,140 people, or how does that work?
So right now we have, I think, the ability to see around 600 with the nursing staff we do have and that we've already ramped up. And then this nurse, as we continue to see increase in enrollment, will then take on more of those. And if enrollment just really skyrockets, we might come back and be asking to start the January nurse earlier. But right now we want to be fiscally cautious and kind of see how it continues to roll out. But that's really the goal.
So on the system of care conversion for the 8 FTE, do you know how many student or how many young people that will serve?
I do not know that number off the top of my head. I'm not sure if Shannon is online still or not. Shannon Brister's the program manager that oversees all of that, and she was logged on, but she may have logged off since our part. Oh, nope, she's there. Yay.
Go ahead, Shannon.
No, 86 clients were seen last month. Wraparounds got a cap of 15 clients per full-time FTE. And I know the math will be a little bit different on this. So each care coordinator has to have a family partner. So it averages out. We can see up to 98, but we have some staffing shortages. And so last month we saw 86.
The Fidelity model requires those limits because of the intensive nature of the services.
Okay, thank you.
Thank you for asking that. Yeah, thanks, Shannon.
And I think Jim has a question. Jim?
Just briefly, because you say it's covered and reimbursable by all the Oregon insurances. Do we see what rate do we see of either uninsured or underinsured people that are taking advantage of the program, and how does that affect the cost model?
So this program's reimbursable by what we call a per member per month rate.
Shannon, I think he's asking about the Family Connects program. Sorry.
Sorry, I'll stop.
Family Connect, yes.
Sorry, I can't see him, so perfect,
Yeah.
thanks.
So since we've been doing this program, which has not been very long, we have roughly 10 visits per month on this program. 80% have been OHP, and the commercial side has been the other 2 the last couple months, because that rolled out really in January. And we're in communication with the hospital because that's really where we're going to start receiving clients and referrals for this particular program.
Yes, we're working with St. Charles Birthing Center to be able to start really kind of going in there and just signing and offering this service right at birth. And then our perinatal care coordinators who are in our OBGYN clinics are also working with our OBGYNs to make sure all women who are pregnant also know about this service and could access it right after birth as well. I will fully admit I wish I had it after I gave birth to my first child, because I don't know, those of you who have, it can be pretty overwhelming. Did that answer your question, Jim?
I think so. If I have some follow-up, I can get with you offline.
Okay.
Yeah. And I will just clarify, in terms of the underinsured, we don't have an estimate, and we have because it's a new program. And in our model, we have assumed we do not have a factor for that.
And I will add, 'cause we just found out from Oregon Health Authority, one area is, the catastrophic insurance, or the insurance that doesn't cover a lot of preventative. OHA has calculated that in, and they're going to offer to county health departments funds to kind of offset that small portion of people who have kind of that high, what is it called?
Less robust, high
Yeah.
deductible.
Yeah.
Low
So they're taking that in consideration as well.
those people that are, those of us who are too cheap to pay for fully sponsored health plans, yes, I can understand that. And that actually answered my question. So there is a funding mechanism for non-traditional insurance or uninsured.
Yes.
Which is great, because that doesn't always happen. So this was a thoughtfully designed model. Cheryl?
Thank you.
Okay. Last but certainly not least is administrative services. And although I'm up here, I just want to call out, I co-lead, tri-lead administrative services with Chris Weiler, operations officer in the back, and Jillian Weiser, compliance and quality assurance officer. So they're here to help answer any questions that maybe I don't know the answer to. So fiscal year 23 accomplishments for administrative services. I thought it'd be worthwhile to talk about our FTE over time. Here we have a chart just for the 3 service areas from 2020 to 2023. Blue at the bottom is administrative services, orange is behavioral health, and then followed by the purple is public health. Janice alluded to some growth in our department, which is not necessarily a surprise. However, when you look at that growth, we've grown in the service areas, direct service areas rather. So behavioral health is around 42%. Public health is similar, though we know some of that is limited duration related to COVID, and we do expect a decline in terms of FTE and percentage growth. But administrative services has grown 4%. So what we've done over the last year is really focus on how to do more with the same. So the first, same space, more staff. A lot of our time has been spent looking at ways to leverage space for our department. We are leveraging remote work and minimizing increased square footage across Deschutes County, and we're working with IT to launch what we're calling a space app. So you can actually walk into the building and at that day and time identify what locations are free. So a lot of administrative services are remote still, so but more in-person collaboration, innovation, or just necessarily being there to be accessible will be able to happen as they can go into the building and see what's available. So that's pretty impactful for us and our entire department, actually, as we continue to grow to meet the needs of our community. As any good administrative services does, we look at streamlining and then obviously digitizing. So a few highlights from the year. We are on an electronic reimbursement process for all of our expenses, so mileage, travel, P-cards, et cetera. We've worked with IT to develop forms. Now that doesn't mean every department is necessarily on the electronic submission, so that electronic submission then spits out the paper forms that we then route. But this has increased our turnaround, or decreased our turnaround time rather, for much of our invoicing processes. The second bullet here, grant management. Obviously, we live and breathe grant funds, so we had to figure out a way to manage this more robustly. When I first started, we did not have a system in place, and in fact, more often than not, I was getting notified that we were late on a report or an invoice. So we started tracking that with Excel files, but obviously as things have grown and been dynamic, particularly around COVID, we've looked at multiple software solutions and it just didn't land for us. We've actually engaged in a couple different pathways on that. So we built our own. And that open source grant management software won the 2022 National Association of Counties Achievement Award. And I have an amazing group of staff who manage that, and it's allowed for dashboards to be built and whatnot so that information is accessible to managers in real time. It links to our financial system. And then last, on the streamlining and digitizing, we've implemented the release of information module in electronic health records. And what that has done is changed a paper process to nearly immediate. So we know a client's needs electronically and nearly immediately whether or not they are okay with releasing information. So that's been a really great turnaround that we've been able to see. And then last but not least, reducing errors and rework. Oh dear, the amount of rework that occurs. And I'm actually going to say even human resources at that, but probably about a year ago, had wished that this was implemented before we ever did. But we have a number of data elements across multiple systems that the managers and other staff within the department needed to collect and find and fill out forms. And this happened for a variety of things, both internal and interdepartmental. So we launched a new supervisor training quarterly, pulled all that information together so that it's in one in easy to read dashboards. And hopefully we're seeing less rework. We're hearing that we are, but we don't have any necessarily data elements to that.
Thumbs up.
Jim. Oh, great. Thumbs up from Kathleen.
I could give you a thumbs up too if you want. In general, do you feel you're kind of at stasis with the remote workspace? It kind of got thrust on you because of COVID, but now do you think that you've kind of hit a baseline and you're implementing some things to kind of tweak your way up in terms of efficiency?
We would like people more present in offices than they can be right now. So we do appreciate the possibilities that remote work and some further innovations like the ability to electronically check out an office to drop into, which are about to roll out, I think, this month. But what we're finding is that actually staff morale and the amount of work that gets done, the innovations, the collaborations, the real-time conversations that happen when bodies are in offices is significant. So we're going to continue to have some staff who work remotely or maybe work half or 80% of the time remotely, but we are working our way towards people back in the office. And interestingly, the Surgeon General released a report about the effect of loneliness and the loss of connection on people's health and well-being. So I felt very validated in my efforts to bring people back to in-person because I watch people smile and connect and talk, and it's important. I don't know if that answered your question, but.
No, yes, it did. It's interesting because there's so many places that try this and then decide, and it's a pendulum one way or another.
Yeah.
But that pendulum comes with associated costs because I know at one point or another you were actually pursuing a building and then you gave that up. I've seen the other comments on effective use of rental spaces and all the rest, but. Yeah. At some point or another, as you scale the organization and as you look to go identify that's going to be, more costs that you're going to bring back that you have to absorb.
Yeah. Yeah, we're really, remote work is still going to make it possible for us to use less space for sure. But what we don't want is a workforce where we have lots of people that are 100% not in the office. That does not turn out to be a healthy dynamic. So we have a lot of sharing of space in our current design.
All right, thank you.
Yeah.
Can you expand on that with your special request on this theme of space? How do your special requests impact space needs? Will there be any additional space needs because of the additional FTE or because of the work that you're doing, you'll be able to absorb that within the space you have?
The only staff that will require additional space that are new are the nurses. Everything else are positions that already exist that were already accounted for in our space configuration. So those 2 nurses would require a space, although the Family Connects program is mostly a cubicle drop-in workspace and working in the community. This is a home-based the whole purpose of that program is you don't make a mom with a newborn baby come to the office. You go to her house and work with her. So the space needs for that program are nominal.
couple thoughts. I mean, I remember when I first got elected and I went over to the health building, just a meeting, and I was surprised. I mean, it filled up the conference room down there, but you couldn't even get probably half the staff in there now. You know,
In the conference room?
together, yeah.
Yeah, yeah. That's why we have virtual technology in all our conference rooms.
And I attended a virtual meeting where
Yeah.
everybody's on there, and then, yeah, that's not as well connected, so.
Yeah, yeah, we're doing a lot of hybrid now. Most people want to see each other, and then people who work more remotely or who would have to drive from Redmond or Lapine are able to join remotely, and that's turning out to be a really useful way to do meetings. So that technology's been great.
Barbecue in the parking lot sometime if you want to have a.
Please.
a get-together.
Yes.
'Cause I can just see it, people are going in all directions at all times, aren't they?
Yeah, yeah. It's great.
One thing to know on the space in our special requests is that while we may not need additional square footage related to that, we may have incur some one-time expenses to optimize the space. Not all, some of those expenses are built into the budget, but not all of them at this point. We would seek and leverage other dollars where appropriate if we went that route.
I think we have one more special request slide. So our fifth special request, and we're forced to prioritize, but I don't want the number 5 to suggest that this is not critically important. This is a role that we created to help us really do a number of things. It's our DEI strategist role. It is a senior management analyst. It is intended to report to Jillian's team and really be part of our continuous quality assurance team, doing lots of things that team does, but doing it through this lens of diversity, equity, and inclusion work that we're frankly required to attend to by nearly every contract, statute, and funding source we have. So this role at this point would lead our equity and inclusion work group, which has done a lot of work to help bring training, review policy, help vet certain recruitments where that's a key factor, helped us a lot with our language access work, with getting the word out about language services, helped us develop that policy. That's just a few of the things that group has accomplished. This role would interface with any of the Central Oregon Health Council or CCO or COIC equity work that's being done to address social determinants of health and health inequities. This role will help us maintain compliance with multiple grants by reviewing policies, developing work products, and things of that nature. It is an existing role. It's in the budget, but it terms at the end of this coming fiscal year. And we have a candidate we're just about to make an offer to, and we're asking to convert this role from limited duration to a regular role with the department. So that is a cost of $142,510, and at this time, no general fund is requested. It's covered as all of our admin tranches covered with contributions from behavioral health and public health. So all sources of funding support these kinds of roles. Questions? Questions about special requests?
Well, just acknowledging, so it sounds like this DEI strategist would be a kind of a resource for the community even. You know, you're referring to all the different agencies that could utilize the strategy work.
Yeah, potentially. I mean, this will be a really interesting role because we're still building it. And I think as we've talked internally, we really want to build this role from the lens of how equity work improves the way we serve our community. Like, that's the focus. And that means they will be externally facing as well as internally facing. So how are we designing services to reach everyone, and how are we interfacing with parts of the community? I mean, I think about the work we did during COVID with our Promotores de Salud model that really went into the community and helped people who were Spanish-speaking access information about COVID, wraparound services to support them when they were being really impacted by COVID and vaccine. That's an example. So that's the kind of project work that we envision for this person. And we'd like to keep them, and it's hard to keep people in a one-year limited term duration position. So, and we have a really exciting candidate. So that's the ask.
So,
Kind of in addition to this person being a resource for the broader community, will they be so health specialized that they would not be potentially useful to other county departments as well? I mean, if
Well, remember that we're 420 staff and a large growing community with a lot of need. So they're going to have plenty to do just supporting the department and our immediate partners. And that may not be a popular answer, but will having a role like this in one of the county's largest department have a positive impact on the county at large? I think it will. And will we absolutely extend any sort of training or development or opportunities to other departments within the county if they want to participate? We absolutely would be willing to do that. So,
Janice, if I could add,
Yeah.
one great example is the work done language access out of the health department that
Right.
we started to replicate in other county departments.
yeah.
So that was very helpful. The language access coordinator came and taught us all the systems she set up in terms of iPads and contract services. And so that's been very helpful to replicate that in other county departments.
Yeah, and I just want to call out that Elizabeth Sanchez got what is the acronym? Oregon Interpreter Association. I forget the exact acronym, but it's a statewide association that really supports best practices in providing language services to people. And our Elizabeth Sanchez, who's been really amazing, got the Interpreter of the Year award. Absolutely earned it and deserves it. And yes, Eric, thank you. She has brought her package that she's created for us, her skills and her expert knowledge about how to use language services in a way that's welcoming and useful to county departments and also to the Central Oregon Health Council and other entities. In fact, we've been fighting off poachers for a while, and thankfully we're able to have her work out a class, which helped us do that, and we're going to work on keeping her. So, yep, that's a great example. Yes, ma'am.
So I'm supportive of the request. I don't know if you're looking for initial head nod on them at this point, but I'm supportive of the request. I think they are reasonable requests and concerned about long-term projections,
Yeah.
obviously. And I'm also would be in favor of carrying forward those funds that you spoke of earlier instead of returning them to the general fund. So I want to thank you for all the information. It was a lot of information, but I think they are critical to your work, and so I would be supportive of the requests that you've made today.
Thank you.
if I could just follow on Judy's statements. Can someone review for me the whole structure and kind of criteria for the return of the funds? What is the setup? How does that work again?
Cheryl can do that.
Oh, thanks,
Oh,
Janice.
Cheryl.
I got it.
It's a,
Okay,
No?
go for it.
Cheryl's got it.
Yeah.
Well, I don't have the specific numbers in my head, but if we were at a specific level of beginning working capital, which was 12 million,
Yeah, yes.
do you know the specifics?
I'd have to pull up the specifics, but I think at some point we should talk the difference between, just to remind folks, the difference of public health return versus behavioral health return.
Right, I was specifically talking about the one where you mentioned that there were no reserves.
Yeah, so public health has no reserves and is returning some general fund, but also requesting some general fund, so it evens out. If they, in fact, do what you are describing, I would have to rely on Cheryl to sort of explain what that would look like in terms of not returning. It would allow, I think, an additional $162,000 in the budget for public health.
That would be 168,661.
Yeah, I think we should review, because I don't recall it ever being necessarily directed to public health, or I don't recall that being the intention of it, but maybe
Yeah. What we agreed to last year with the budget committee was specific to behavioral health.
Right.
The special request on the public health side was to cover half of the health officer position. So since that position wasn't filled, we didn't incur the expense. So we thought it best to return that county general fund, or at least offer it. But we were not required to do so based on motion last year.
No, yeah, the motion last year was specifically directed to the behavioral health reserve, not to public health. As Cheryl said, they didn't fill the position, so they were thinking about transferring it back to the general fund because of, but I don't think that was part of the motion. The motion that passed last year was based on the sum of their beginning working capital plus their reserves. And if it was over a certain level, it meant that their reserve had grown by about $1 million this year. So they would be returning that amount of general fund back to help with courthouse and other future long-term funding. Otherwise, the general fund would just be sitting in their reserve at $15.8 million right now for future use for behavioral health.
One correction, it wouldn't sit in our reserve. We would probably save it for future years as we incurred additional expenses.
For example, it's what we will probably have to rely on to cover the difference in the cost of what was currently funding stabilization services and what is now gone. So 1.2 million happens to also be the amount that the impacts grant was. Yeah. So, and I don't know if at the time the relationship that Dan is describing is accurate. I don't know that at the time we were understanding that that was about funding the courthouse. It was simply an acknowledgement that we had a huge reserve, that it didn't look like we needed it to cover costs in the near term, and that there was an agreement made that we would return some to county general fund. So I don't know that it was directly related to the courthouse when the policy decision was made by this group
It's the board, it's the idea is that if it stays in the general fund, and I apologize for saying sitting in the general, in your reserve, because the reserve has many purposes, including the expansion of services, your capital services, and stabilization center. But the intention was that if it stays there for a year, you can no longer, as the board and as the budget committee, use those general funds in the future, or we have never asked to retroactively pull out general fund 2-3 years from that reserve. So when we're facing things like the courthouse, not specific to the courthouse or the public safety campus or other space needs or community asks, that would be returned to the general fund so that the board has a plethora of options where they can determine where those funds go. And if the board determines that behavioral health and expansion of behavioral health services is the #1 priority out of all the priorities in the county, then it would simply be returned back to them. But this frees those funds up to go to any of those projects.
So those are, and there was a lot of discussion about that policy, and the understanding, there were some proposals that we might put that in a reserve for behavioral health to pay for some of the costs we're in fact going to occur in the coming year. Stabilization center, space, moving cost, facility costs, and some reductions in potential revenue. So that's just the reality. That's what that return equates to, is that those dollars are not then available for that. And I don't think allowing those dollars to stay with us means we're being prioritized as the primary commitment of the county. I think it just means that we're either being allowed to keep reserves that we've saved or help contribute to offsetting other costs that the county incurs.
So I have a question
They're
about.
also facing a significant degree of uncertainty about future revenue.
The whole county is. We are too.
Well, yeah.
Yeah. The whole county is, yeah.
But the rest of the uncertainty about revenue for the county, I understand way better than I understand the uncertainty of the revenue for your department. Because it's extremely complicated.
Yeah.
So finishing up the North Campus in Redmond, that that we're spending $1 million on that? Has that already been spent? Has that been allocated?
The county spent the $1 million on the courthouse expansion.
No,
And
I'm
then
not
we are, or more than that, actually, we spent, well, $1 million on furniture and fixtures, and then we had a little bit of overage, which amounted to,
Roughly 250,000?
$250,000, which we covered out of
COHC.
COHC funds.
Okay.
Yeah.
So was that money already spent
That money has been spent
this year?
this year. Yep.
So one other comment on the additional, the $1 million, that portion of it, that is in our general fund long-term forecast. We included that when we presented just about a week ago.
Yeah.
So we are anticipating those funds coming back to the general fund, and then it's part of the pool of resources that we have for future decisions. I think what I've learned through catching up on last year's budget motion and recommendation from the budget committee is the contributions from the general fund to health services or for public health, and that the 168,000 was to help cover those costs that they were going to incur. So since they didn't have those costs, that's why those funds are returned back. And as Cheryl mentioned a minute ago with public health, they didn't incur the costs out of good faith. That's why the funds come back. Similar to CDD, we help support community development. We provide general funds for those services when they need it. When their revenues are higher, the funds come back to the general fund for that service because they didn't need it for those services. Since the general fund is this discretionary funding for that. So just to add a little more context. So at least that's how I understand it.
Yeah, and I would say if their reserve shrinks at all, no general fund comes back. The agreement that we had was that if the reserve grows, and I believe it was $1 million, grows by $1 million plus beginning working capital, then they would return. So not only did it have a safety net, but it had an increase. And so it did grow that much. I think it went from 13 point something to $15.8 million. And so in that way, when you return the general fund, it does open it up for more projects. And because we did put that 1.2 in the long-term forecast that you and Jim saw, it is technically in that forecast dedicated to the first payments of that courthouse currently right now, because we weren't able to see us being able to pay for the courthouse all the way through. In fact, if we don't get that payment in the general fund, beginning working capital will drop by 1.2 million. It will be 1.2 million less transferred to help begin to pay for those courthouse. And the reason we have this, we also have this set up with other funds too. Health is not the only fund that has this. They're just the fund that has the largest probably concentration of discussion around it, and also the largest concentration of health of funds. We do this with CDD, other funds, but those are in the $100,000 payback. And the intention in all cases, and I know it can get a little confrontation, or not confrontational, but it's contentious because everybody wants this these funds. The intention in all cases is to return the general fund back here so that the board and budget committee can prioritize what they want to spend on. And if it's not returned, then it does stay with health services, and there's not that same amount of dollars, in this case $1.2 million next year, to discuss, should this go towards the courthouse, should this go towards the stabilization center, and so I think that is the intention of it, to make sure that those dollars, that we have the total amount of dollars, and that they can be discussed for whatever the current priority is.
And I want to be really clear, we're not suggesting that amount comes back to health services. So that's not what this conversation is about. But we are in a different position this year than we were last year. And we had that additional $1 million because of some unfortunate circumstances, such as significant vacancies that impacted our ability to generate revenue. So we don't love necessarily being in the position of being able to give that back, because it means we were not necessarily operating at the level that we hoped to be. We hope that this phenomenon is a one-time. That's our hope. And we are looking at considerable potential shortfalls and key services that we're trying to maintain, and the need to account for staff space needs. So that's really the impetus behind my discussion about this.
I would like to ask about the $12 million number. I mean, for some of the other departments, I understand how kind of a target reserve level was set, but I mean, can someone walk me through why $12 million is the magic number for health services or behavioral health?
I can walk you through where we were at in that conversation last year. We actually did go through the exercise to identify a minimum reserve level, but when we look out multiple years, we sort of threw it out the window because we were going to use it based on what we knew. But that recommendation, when we looked at other jurisdictions, it was 25% of our operating capital. That $12 million number specifically last year was just, we came to an agreement that our budget number in the reserve, if it was better than we thought it was going to be, and we thought it was going to be at 12 million, if it was better than we thought it was going to be, then we should return county general fund. And how much could we return would be anything we don't use for match, so the requirement, plus any specific policy decisions, such as the Crisis Stabilization Center staff. So that's how we came up with that number.
But did you just say that, kind of other jurisdictions identify 25% of their operating capital for the year as a more appropriate reserve level?
It was all over the map. There, many community mental health programs and so we surveyed our community mental health program partners. There were a couple that had a 25% policy. One had 50% in reserve. I don't know how they did that. Many have nothing. So it's pretty all over the place, and we landed on that as the one that was the most frequent and was the most comparable in terms of larger counties that had some reserve and had an actual policy or a standard in place. So that's where we landed on that. But the 12 million was really a point in time. We had it. The discussion was, should you keep it? If you get more, the policy decision was no, if you get more, it should come back. And what we gave back was literally everything that we did not use to do one of two things: cover the policy decision that was made about the stabilization center, which I think was $244,000, and then whatever we needed for match requirements in behavioral health. And that's it. That's what we've kept in behavioral health. So I think our overall percent of general fund in behavioral health is somewhere around 4%. 5%. It's gone down significantly, percentage, not cost, percentage every year. Public health is a different story. Yeah.
So that's 4%.
Yeah.
General fund requests flat from last year, $2.2 million.
Yeah.
I would just say one of the reasons that we brought it up again last year is because the health has such a dynamic funding model, and it's so variable that it's very hard to project health services forecasting long-term. So sometimes it projects that it's going down and you have a 10% surprise or a 15% surprise, or built into your assumptions is that you keep regular duration positions when the grants end, and sometimes you guys don't make those decisions. As we saw, you're decreasing FTE. And so I think that's also part of the reason too, because in the past, sometimes we had projected that you guys would lose funding, but you actually, as you did last year, you actually gained a lot of funding. And
right.
So we always try to give you the general fund that you need in case you do lose the funding, right? And then I think at like a certain reserve level, and then I think if you guys end up doing better than that, the idea is that it goes back for general. At least that was the discussion last year.
Yeah.
But I just still want to ask the question, what is the appropriate reserve level given the uncertainty of future revenue? I mean, given the uncertainty of future revenue and the, really substantial operating costs for this department, for this division,
if things go south on any given year. Because,
Yeah.
when this is showing that, the behavioral health budget for this coming fiscal year is almost $56 million, of which the county is only covering 4% in general fund. I mean, that is a lot of other people's money that we're depending on, that, as we've heard, is not so certain. And $56 million is a lot of expenses to cover with reserves or some, I don't know what else, surprise money. If all that anticipated revenue doesn't come through. So I think it is appropriate to ask the question, what is a reasonable reserve level to address, those risks of big changes in incoming revenue, and still being able to maintain our commitments.
Well, and I just want to add, and I'm adding because this is my opportunity to do it. You will all have conversations when we are not here and can weigh in differently, and I'm sure that will happen. But what I really want you to hear is that behavioral health reserve supports a lot of things besides just behavioral health. We pay 70% of our overall revenue towards all of our administrative services costs. Some of public health's costs have been offset by the ability to use our behavioral health reserve. For example, our prevention program was able to keep some revenue and have some additional costs covered because of behavioral health reserve. We can justify that one because it's in the behavioral health lane. Another example is our covering of some of the space costs that are going to be incurred. Another example is taking on harm reduction, moving that program into behavioral health, taking that cost out of public health where we knew we could shore it up. It is a life-saving service. So I think the notion that this is just behavioral health money that we only use for one side of the organization is probably a misunderstanding. It's part of why we could move general fund to help meet the county match for IDD without having to ask for additional general fund revenue. So I just want that to be understood. And the other thing I would say is right now our general fund draw is less than what behavioral health pays downtown for internal services costs. So, I think we're doing a lot to come up to the line and meet the need. And of course, my preference is going to be to hang on to revenue to protect the work we're doing in the community in the future, knowing that we have big costs coming. So that's my bid, unapologetic. You can talk amongst yourselves. Thank you for letting me say it.
I just did a quick calculation, and 25% of $55.8 million is about $14 million. So, I mean, it's not 12, it's 14.
So Robert and Dan have kind of explained, I think, what's most important here for us today is this is part of the overall budget.
Right.
It's been locked into the budget proposal, and I think we really need to see what that proposal is. This is one department, and I think we're going to hear about other departments that have similar issues for us to deal with. So we're not going to be able to make a decision about that today, which I'm not prepared to do until
we don't expect that.
Hear more input. So I appreciate the clarity and the understanding that we've gotten from this discussion, but I think there's not a whole lot more we can do about it until we get the full budget proposal.
I do want to flag, and we've already made this, it's built into the budget for the budget proposal for the coming year, but I would like to flag for future years that the, $12 million seems like a very arbitrary criteria number that in future years we provide behavioral health and health services the opportunity to build that reserve higher, because it seems like it might be what's appropriate to address future contingency.
And I would just say that the 12 is the number, but current year actual, they're at 15.8. So in terms of your reserve fund.
Yeah,
when we're talking about.
I think he was talking about the appropriate amount for, if that policy decision were continued in the future, what would it be?
Yeah.
We're not asking for that, but we're also very happy to return 1.2 million to the county this year.
But I hear Commissioner Chang saying maybe there's a conversation, and we had a conversation prior about what the right number is for reserve, if it's 25% of your operations or something like that.
Yeah.
All right, we're at
Thank
the
you
point
all.
of summary and closing remarks. Do you want to make a summary?
Sure, just so that it's clear, we're asking for 3 new FTE above the proposed and continuation of 12.5 FTE. We do have a county general request of $23,096. That's already in the proposed budget, so it is not an increase to what you see in front of you. So that summarizes it. That's an increase in county general fund of 3% from fiscal year 23. And overall, in terms of FTE, if the special requests were approved, it would be 414.8 FTE, which is a decline of almost 2% from fiscal year 23. And that's it.
Thanks for the time. As you know, any questions that any members of the committee have for, that you want us to focus on for when we return at the end of May for the actual budget hearing, just let us know. Probably the best route is to get it to Cheryl, and she farms it out to the people who can answer, which is usually her. But
Before you leave, let's ask the group and Jim if there's any other questions or comments.
yeah.
I am good. I have no further questions, and I certainly appreciate the health services coming in and doing a thorough review, and it's worth my time to do this. Thank you.
Thank you.
I have 2 items. We don't need to take them very far today, but in the report, annual report, it talks about IDD relocating program offices. So, maybe there's a, what's going to happen with this facility and where's IDD going? Just a note that you want to say something about that real quick?
Yeah. So we're out of space in the Wall Street Services Building. We did a whole space planning exercise that was facilitated with programming tools. And IDD is going to take the Antler Building as their primary location and have a smaller location in the Wyatt Building. So they will move into those 2 spaces so that Wall Street Services will take on the other side of the Wall Street Services Building, because they were completely out of private offices, and it was really actually impacting the ability to deliver services, bill for services, just not tenable. Reproductive health will remain at Wall Street Services for the time being until we go through a process that we're planning right now with Mosaic to look at the Courtney Clinic and see if there's some opportunity to cobble together some public health dollars, some behavioral health dollars, and some FQHC dollars to maybe expand clinic space there just through a remodel. Probably a pretty simple one, because but there's not a lot to apply to that. So those are the moving parts. The Williamson lease ends in November. Ends in December or November?
Williamson?
Yeah, or no, April. Yeah, we're hoping it can end sooner, because then we could save those dollars. And once we're out, they may be able to lease the entire building. We'll move those folks to Wyatt, a number of other teams to Wyatt. So there's a lot of this going on. Yeah. But the good news is we found a way to use the Antler Building, which to help address some of the space issues. So that was really helpful.
And I think you said 2 items?
No, that's enough.
Okay.
Yeah, these are budget as much as just other questions.
Yeah. Thank you.
Just a couple of last comments here for the Budget Committee. I want to thank you for your time today. This was an informational session prior to Budget Week. As a reminder, and for those listening, Budget Week is May 22nd to the 25th, and we will have a couple long recess breaks on the Monday and Tuesday. That's why we're also having a couple of these informational sessions. Reminder, May 17th will be Visit Central Oregon. We'll be providing a presentation that we've already heard from EDCO. And right now at 12 o'clock, we'll move to the next part, employee elected officials compensation meeting for those members included on that. Thank you for your time.